हाँ यस वो पूरा क्लियर आ रहा है।
और थोड़ा सा
तुम अपना
नहीं तुम झुको
नहीं झुको मत, लैपटॉप
हाँ ये बढ़िया है।
लैपटॉप का लिड ऊपर नीचे करो.
So they जाऊ दे आता, it's not possible actually.
My God, Dr. Shreya Thate has a pet at home, I think.
Yeah.
Good evening, everyone. Can you hear me?
Yeah,
Yeah.
But I am not able to. Yeah,
we can't see you, but
my video is actually not working. Camera is not working. So
Good evening, everybody. Good evening, all our participants for the talent search of the East. Sunilji, can you mute everybody else, please? So welcome to our talent search of the East, and welcome a very, very warm and a hearty welcome from the team Scientific Committee AIOS. It's really a pleasure to see the young budding stars present phenomenal, challenging videos, challenging cases, studies that they have done. And it's really admirable for all these presenters to come up and to share the screen. And to share the screen with the judges who are known for their greatness in their own specialities, in their own fields. And I welcome all our judges today. And thank you for being with us for the next 2 hours. So this is a very important talent search for us. And I'll just introduce to you our chairpersons for this evening. And of course, the AIOS Governing Council, the ever supportive AIOS Governing Council, has always taken things forward and has been an inspiration. But the hard work has always been done by this team of Dr. Amit Porwal, Dr. Fairuz, Dr. Jatinder Singh Bhalla, Dr. Krishna Prasad Kudlu, Dr. Parikshit Gopte, Dr. Som Shilamurthy, and Dr. Sonu Goel. We have with us Dr. Mahipal Sachdev sir, our chairperson, President AIOS, Chairman Scientific Committee, IRSI, and Chairman and Managing Director, Center for Sight Group of Eye Hospitals. Sir would be coming in very, very shortly. Thank you, Dr. Lalit Verma sir, our chairperson, Vice President AIOS, and Senior Consultant, Center for Sight. Thank you, sir, for being a part of this program. Thank you, Professor Namrata Sharma, Secretary AIOS and Professor of Ophthalmology, Cataract, Cornea and Refractive Services, AIMS, Delhi. We have our wonderful moderators, Dr. Krishna Prasad Kudlu and Dr. Som Shilamurthy, who have done a huge amount of hard work to get everything organized. I invite our judges, Dr. Mangat Singh Dogra, sir, Director, Retina Services, Grewal Eye Institute, Chandigarh. Thank you, sir, for being with us. Dr. Kim Ramaswamy, CMO at Lions Arvind Institute of Community Ophthalmology, Madurai. Welcome, sir. Welcome, Dr. Surendra Singh Pandav, Professor of Ophthalmology at the Postgraduate Institute of Medical Education and Research, Chandigarh. Dr. M. Vanati, Professor in Ophthalmology, Cornea, Ocular Surface, Cataract and Refractive Surgery at AIMS, New Delhi. Welcome, Dr. Vanati. Welcome, Dr. Rajesh Fogla, Director, Cornea Clinic, Senior Consultant Eye Surgeon at Apollo Hospitals, Hyderabad, and visiting consultant, Lanka Hospitals, Colombo, Sri Lanka. Welcome, Dr. Chaitra Jaydev, Joint Secretary AIOS, Senior Vitreoretina Consultant at Narayan Netralaya Eye Institute, Bangalore. Dr. Mallika Goel, welcome, Dr. Mallika, Senior Consultant, Retina Vitreous and Uveitis, Apollo Health City Campus, Jubilee Hills, Hyderabad. Welcome, Dr. Shreya Thate, Professor and HOD, Department of Ophthalmology, Sri Aurobindo Medical College and PG Institute, Chandigarh. Indore, sorry. And with this, I would request our chairperson, Dr. Lalit Verma sir, to say a few words. Lalit sir.
Yeah, thank you, Partho, for having me here. From west to south and now east. What better? You see, I was just thinking, what a great scientific committee is this. You see, because I believe nothing can be better than recognizing the talent. And this is the whole job of scientific committee, very ably led by none else than Partha Biswas. You see, recognizing talent and giving chance to all the AIS members to participate is a very, very big exercise which this scientific committee has undertaken. And this, I believe, is the only way to recognize talent. And this is the only way when how science can progress. And this scientific committee is fulfilling this job of recognizing this talent very, very nicely. Believe me, I'm very, very impressed by this exercise. Remember, these are very tough times all of us are going through. We are seeing second wave or at some place third wave coming up. Very difficult times, but
something is wrong.
But for this scientific committee, nothing seems difficult. So, congratulations to Partho and his team of young scientific committee members, doing great job. And I'm sure KP and Somshila, who are the moderators for this east part of the Science Talent Search, will do a great job. Best of luck to everybody, and all the best to all the participants, and judges are, I am sure, will do a great job. Thank you, Partho.
Thank you, sir. Professor Namrata.
Partha, congratulations again for yet another show, Talent Search series, now East Zone, and great work being done by the scientific committee, especially because it has been compartmentalized into various zones. And we've been witness to very nice presentations, which are most scientifically acclaimed in the last two shows as well. I'm sure we are going to have a great academic and a scientific feast today. And this is one way of giving a chance to people to showcase their work. And I'm sure in the end you will come out, with a person who is mega talented, who would be the talent of AIOS. But having said that, I think it is important to just participate, to be there, to be representing your zone, and to be showcasing your work. Because sometimes it's not about what we judge here; it is much more than that. Which entry will be judged is a different thing, will be the best is a different thing, but all of the things which are going to be presented are going to be unique in their own way and will be useful in their own specialities and will have a place in each of the pathologies of the diseases of the eye. So each one of them is important, and wish you all the best, Partha, and thank you again for doing it. And Dr. Kudlu and Dr. Somshila, I'm sure you're going to do a great job.
Thank you, Namrata. So over to our two great moderators of the day, Dr. Somshila and Dr. KP Kudlu.
Thank you so much, sir. I think me and Dr. Somshila will take you through the whole competition. I think 10 of the participants. As usual, I think all the other zone, what we are following, the same rules we are following here. We always go with the alphabetical order. According to the alphabetical order, first I invite the first speaker, that is Dr. Amrita Mohanty, and she has done her fellowship from Yelvi Prasad Eye Hospital 2007 to 2018, and also she has got a few of the international journal presentation also, but currently she is working as a consultant in Yelvi Prasad Eye Institute, Bhubaneswar. So I think basically she is a cornea and anti-segment fellow, looking for her performance. Over to you, Amrita.
Thank you, Dr. Krishna. Good evening, all. I'm going to share my screen. Yeah.
Sunilji, the cue for the timing you will have to give. Sunilji?
Yes, sir.
Yes.
I'm waiting for the presentation to start. I'll start the floor.
Yes. So at 3.5 minutes, there will be a voice, a reminder that half a minute to go.
Sure, sir. Noted.
Good evening, everyone. I shall be describing a novel corneal epithelial entity which I encountered in a fine morning of June 2019, which didn't have any textbook description. So he was a 31-year-old male with a history of pain, photophobia, blurring of vision in left eye for past 30 days and was treated with topical ganciclovir elsewhere. There was no predisposing risk factors like presence of any trauma, foreign body, contact lens wear or exposure to toxic substances. The lesion was quite unusual. It was superficial with a ridge-like appearance, amoeboid in shape, and the fluorescent stain revealed a punctate staining. Rest of the cornea was within normal limit. The tear film height, the corneal sensation, and the blinking response was normal. So luckily, the patient was seen in 2017 by one of my colleagues, and the clinical picture was quite surprising because he had a similar lesion but at a different location. Microbiology was negative in 2 occasions, and with each scraping, the lesion changed its shape with a regression in a centripetal direction, and with topical lubricant and antibiotic alone, it resolved with a clear cornea at the end of a month. So again, coming back to my case in 2019, we did a scraping, and I was not surprised that it was again negative. And we started the patient with topical antibiotic and lubricant. And we did at day 21 superficial epithelial debridement and sent it for a histopathology because it was obscuring the vision. But to our dismay, it again recurred underneath the bandaged contact lens, and it started changing its shape. But luckily, under lubricants alone, by the end of the 3rd month, it regressed with a clear cornea. So looking at this clinical picture, the first differential diagnosis which came into our mind was CIN, which was ruled out with histopathology in our case, which was suggestive of squamous metaplasia and discohesion and some degenerative changes. However, there was no cytological atypia, no deposit in various stains, and no signs of inflammation or infection. Again, anterior segment OCT was also not definitive of CIN. HSV was ruled out by doing a PCR, which was repeated thrice. Other superficial coarse epithelial lesion and systemic association were also ruled out. We had a déjà vu kind of experience when we saw our second case, which was a 14-year-old male, which also had a similar kind of morphology, and we followed the same protocol. And in this case, we did a corneal epithelial debridement early, and it resolved with a Fendt scar at the periphery at the end of a 2nd month. Looking at this entity, the first term which came into our mind was migratory epitheliopathy of unknown etiology. But as the etiology will be known someday, so we shifted to the term migratory serpiginous corneal epitheliopathy, looking at the morphology of the lesion. So we talked about this in our peer group, and these are the 2 cases which closely resembled our first 2 cases, and they were microbiologically negative, and they responded to topical antibiotic and lubricant. So all these 4 cases were collated and published last month in the esteemed ocular surface. So journey so far of MSc was not that easy, because while dealing with the first case, we really had a sleepless night in chasing the etiology. Even convincing the reviewers that it is possibly a new entity, but we could not ascertain the etiology, was a very difficult job. The reason why this is a cluster of 4 cases, why I'm presenting in this big platform is because the reason still remains unknown to us. And by spreading this entity to as far as possible, so we can go into the journey of known to unknown. What is known? It is possibly a new entity, but the etiology still needs to be certain. It recurred, but how long, how far we should follow up the patient? Although the first patient has been followed over 15 months without a second recurrence, we don't know exact course of the disease. It responds to epithelial debridement, but possibly the gold standard treatment will change depending on the etiology. I strongly believe that picture is still baki, and I have the fire in my belly to know about the exact etiology and nature of the disease. Thank you for a patient hearing.
Can you stop sharing the slide?
Yeah.
Thank you so much, Amrita. I think to discuss this case particularly, we have got 2 leading cornea surgeons of India, none other than Dr. M. Vanati and Dr. Rajesh Fogla. Over to Dr. Vanati.
Thank you, Dr. Kudlu. That is, I think, a very nice and a very new entity which we looked at. I would like to ask Amrita that did the patient have any history of contact lens wear, any history of trauma? Was an immunology workup also done for the patient?
He didn't have any history of trauma or contact lens wear. Immunology workup was not done, but his ocular surface was normal, tear film height and corneal sensation all were normal. So, and also in the histopathology, there was absence of any inflammatory cells. So what we thought of was it was probably an abnormal reparative response.
Okay. And you did get a viral antigen testing also?
Yeah, we did it twice in both of our cases, and it was negative.
I see. So you couldn't pinpoint on any particular cause, and that's quite an exciting, a new description of a disease entity out there. And all your 4 patients are quiescent on just lubricant therapy?
Right. And yes, ma'am. And 3 of them responded to epithelial debridement. We had to take the patient to the OR, and we scraped off the epithelium. It was and we plated it over a moistened filter paper and sent it for histopathology. After that debridement in the OR, 2 of our cases didn't have a recurrence.
Okay, yeah.
But they do recur after repeated scraping.
Okay, so no evidence of any evaporative dry eye disease or
No.
anything that nothing akin to a hyperplastic epithelium or anything. That's quite an interesting entity, and I think you've really documented it nicely to show the serpiginous nature of the epitheliopathy which is there. I think you must have ruled out any drug intake in this patient as well. Yes.
Yeah. Only there was a history of use of topical ganciclovir, but it was present in 2 of our cases. Like case 1 and 2 had used ganciclovir.
Okay. Yeah. Dr. Fogla, any comments from you on that?
No, it's a very well-documented series of 4 cases, and I did go through the paper that they recently published in the Ocular Surface Journal. Few points. It appears to be primarily an epithelial problem. If you look at the fluorescent staining, there is no epithelial defect. Only you see a heaped up epithelium, which gives that outline of that geographic pattern. And clinically, if you come close to it, it resembles like an epithelial rejection line that you see post-corneal transplants. The only thing that I wanted to ask was, since it's unilateral, so you can rule out conditions like dystrophies and maybe some systemic association. Any evidence of any lid disorders, lid laxity, floppy eyelid, or something which could have resulted in the lack of thermos kind of thing during sleeping?
Yeah, like the blink reflex and the corneal sensation were intact, and apart from few blocked meibomian gland, nothing remarkable.
So it's interesting that and the treatment pattern has varied despite not having any infective etiology. I think all the 4 cases were also treated with some antibiotic, one of them with fortified amikacin as well, which again does not give rise to a cause and effect, So that's again very interesting to see what actually made them better. One possible thing that we could think about is that maybe there could be a primary trauma to the cornea, which resulted in an abnormal basement membrane, and then the subsequent epithelium had a tough time to resurface, and over that area of the trauma, it took several weeks for it to normalize and the epithelium to get back to normal. You did not see any dyskeratosis or any atypia, but what you saw was abnormal epithelial. Yeah, so that's very interesting and very well documented. I think we need to watch out and
I also thought, Dr. Fogla, if I could just add on, I also thought the area within the region of the epithelium looked slightly hazier than compared to the rest of the epithelium.
Yeah, but not as hazy as what you see in CIN. CIN,
that's
you
right.
had grayish, so it was not exactly grayish. Confocal would have definitely added a little bit more information in this. But since they have not seen these cases earlier, I think if they see them in future, maybe they will definitely think about doing a confocal. Only thing is, the other thing that you need to look for is this a dominant eye, like the dominant hand, the right eye, because that can explain some sort of exposure to something. They would have rubbed the eye, introduced something in the eye, why the non-dominant hand, that eye has not been affected. It could be something like a response to a chemical injury kind of thing. It's in the exact interpalpable area as well, so that also makes it.
Absolutely.
So this is very interesting, and any kind of toxic medication makes the condition worse. Whether you use antivirals or a lot of antibiotics, then the epithelium, which is already stressed, will show you more of this abnormal pattern. So debridement and allowing the normal epithelium to heal using lubricants and maybe a mild steroid would be the way to go. but very nice documentation and interesting 4 cases. And an innovative name as well.
Yes, I agree. Yeah.
Thank you so much. Thank you so much, Rajesh. Thank you so much, Vanti. And just to go into the next presentation, is there any other comments from any of the chairpersons or Dr. Namrata?
No, I would just like to ask one thing. There is something which Dr. Harminder Dua also has described, which is, hurricane keratopathy or bizarre sort of keratopathy way back in 1993, which, also has a clinical picture which is similar to this. So how is this different from that?
Probably there was no exposure to any toxic medications, and apart from it, and in the clinically also it doesn't resemble a hurricane keratopathy. It's like it has a typical amoeboid shape, and it keeps on changing. Like every time we scrape it, it will get reepithelialized, and it keeps on changing its shape.
I think most important, which Rajesh also pointed out, Confo scan would give you a clearer picture.
Definitely. Yeah. Probably in future, if we encounter such cases, we'll be able to document it from the beginning.
Thank you so much, madam. Over to Somshila. Unmute, Somshila. Unmute.
Yeah, thank you. Thank you. Sorry about that. We move on to the second presenter of this evening, and the second presenter is Dr. Bibhuti Kashyap. Very quickly to introduce our presenter, he has done his post-graduation and senior residency in retina and refractive surgery from RP Center. He's also done ex-oncology medical retina fellowship in Italy, and currently he's a deputy director in Kashyap Memorial Hospital, heading the vitreoretina and uvea unit. And he has a lot of clinical experience in doing multiple surgeries, and he's going to give his presentation on a very interesting subject. So over to you, Bibhuti, and all the best.
Thank you, ma'am. A very good evening, everyone. So my today's topic is a new indication for endoillumination assisted scleral buckling, that is failed vitreoretinal surgeries. So the case was that of a 48-year-old one-eyed pseudophakic male patient who presented to us with decreased vision in seeing eye since 2 months, with the best corrected visual acuity of finger counting at half meters. He had history of past manner vitrectomy with silicone oil injection for primary rhegmatogenous RD 15 days back in the seeing eye. On examination, there was retinal ray detachment present infratemporally, which reached up to the fovea. Poor pupillary dilatation, posterior capsular opacification, and silicone oil meniscus precluded the break visualization. Hence, there was a surgical plan of performing an encirclage with a repeat vitreoretinal surgery. A 360-degree conjunctival peritomy was done. The recti were isolated and bridled with cotton sutures. Now, we all know repeat vitreoretinal surgeries can have many intraoperative challenges, like performing a retinectomy, accidental suprachoroidal error, spontaneous intraocular bleed, creation of an iatrogenic break, etc. So these thoughts of these complications plus the one-eye status of the patient urged me to change my plan to an endoillumination assisted scleral buckling instead. A chandelier endoillumination was fixed superinasally, and an attempt to localize the causative break was done under contact wide-angle viewing system. The problem was the hindering blood meniscus, as well as the optical hindrance caused by the oil meniscus. However, careful maneuvers obviated these difficulties, and a causative break was localized inferotemporally. A cryopexy was applied to this causative break. sterile buckle was passed inferotemporally 135 degrees. The encircling band was then passed and the final tie was made 180 degrees opposite to the causative break, that is superonasally. And the conjunctiva was then closed in a ship-to-shore manner. On the first postoperative day, the retina was attached with no residual subretinal fluid. The buccal indent was adequate and the intraocular pressure was 20 millimeters of mercury. On the third postoperative month, the patient enjoyed a BCVA of 636 and he awaited a silicon oil removal. So the take-home message is that endoillumination assisted sterile buckling obviates the further intraocular manipulations and its associated complications in an already vitrectomized eye. Hence, it is a safer choice than a repeat intraocular procedure in eyes where a considerably anterior break, whether new or pre-existing, without a fixed fold, is the cause for retinal redetachment. Ergo, going the other way around sometimes may be the way to go. Thank you.
Thank you very much, Dr. Kashyap, for a wonderful presentation. Very exciting. The lead judges for this presentation are Dr. Mangad Dogra and Dr. Malika Goel. Sir, please go ahead and give your comments for this talk.
Yes, I must congratulate Dr. Vibhuti for a very nice case presented here. And of course, a novel technique of doing this endoillumination assisted buccal in a silicon-filled eye. I have few questions for you. This patient being one-eyed, what was the primary status of the retinal detachment when you did the first surgery? Was it a fresh detachment or it was a detachment which was a little older with some PVR?
Sir, actually this patient was not operated by me first up, but the status of the patient on the hindsight as recorded by the previous treating surgeon had no mentions of any PVR changes. So I'm presuming the status of the RD would still have been fresh.
And another question I have for you is, what would be your take on doing a primary encircling band in a surgery in a one-eyed patient versus doing 360-degree laser? I don't know, 360-degree laser is being done more and more, and I don't understand why it is being done. 360-degree is too much.
Sir, 360-degree endo lasers can also lead to some PVR changes in the posterior pole with the formation of some ERMs. And so my take on such kind of one-eyed patients would always be to go for a safer 360-degree encircling band rather than going for an endo laser of 360 degrees, because that will, reduce my chances of having a formation of a fixed fold or a macular pucker. I mean, I don't usually peel off the ILM, so I'll always have a scare of forming an ERM which might lift up the macula. So I'd always go for an indenting band all around.
One last question before I hand over it to Malika. One of the problem in a silicon-filled eye you would have is that it may leak out with your repeat procedure doing a endoilluminated assisted. You see, so if you could see a break, I think it would have been much better to do it without endoillumination. That means from outside. Perhaps, but as you said, your view was poor. You could not see the break. Maybe that is, but that is a real problem, because here, once you are again going in, the oil is definitely going to seep out, and that is something which need to be kept in mind. But if we can see the break and we are fairly in a good shape, I think it would be, according to me, much better to do it from outside rather than going endoilluminate assisted. Dr. Malika, please. Thank you.
Yeah. Okay, that was an excellent video, very, very clear video. Yeah, I agree with Dr. Dogra that in a one-eyed patient, I think an encerclage should be put in the primary surgery itself. That reduces the risks of redetachments, definitely. Other thing is, as he said, if you already have an endoilluminator inside, it's already an intraocular surgery. It's no longer a buckling. So I would have an infusion cannula in place before even I put the endoillumination inside. The first thing to go in should be an infusion, which could contain oil, because you're going to only inject oil, not saline. So that's what I would do. I would put in a cannula, inject oil, and then since you've already gone in this case, I think the detachment was not very bullous. It was shallow, right?
Yes, ma'am.
Yeah. If you felt it was little bullous, I wouldn't mind going and aspirating the subretinal fluid with a cannula, which has active aspiration attached to it. So that will only aspirate the subretinal fluid, but not the oil, because the oil is much more viscous. It doesn't come out easily. So I would do that so that the retina, the break closes more easily on the buccal. But in your case, it anyway closed. So I guess the other thing possibly to do is if you just position the patient well, since you saw the break on the table, if you position the patient well, sometimes you don't need anything more. I've had patients who had a redetachment, just do cryo, position them. The oil goes and closes the break with a prone position, and then you can subsequently add laser if you want to add. Yeah.
Ma'am, in this case, if you would have noted in the post-operative picture, because in the pre-operative picture, the periphery wasn't visualized clearly. So in the post-operative picture, you would have noticed the actual causative break was actually present inferotemporally only, so as the previous surgeon had marked. So he was already having a prone position with the foot in elevation with the face turned to his right side. So that position was already there, and which was not actually helping the fluid to resolve. So, I mean, and because the break was not visualized, that is why, we thought of, entering inside.
One point is that how were you managing to do buckling when one hand was busy with the endo-illuminator? Could you replace it with a chandelier in future so that your hand is free?
Ma'am, actually, I did not have a problem because with my left hand, I was directing the endo illuminator, which was fixed at the trocar. It actually did not. I mean, technically, yes, it did enter, but it actually was pretty much at the mouth itself. So once the endo illumination is inside, the eye is pretty much firm and closed as a compartment. So when we take the cryo and we move it along the edges, that ways, the globe doesn't shrink. And we are also able to obviate the difficulty of the optical hindrance of the oil meniscus, so to say. So it was not at all a difficult prospect. The only difficulty was the intervening meniscus, as I showed, and the the optical hindrance of the oil. But I mean, careful maneuvers will actually take care of those. The other thing that you mentioned was with the use of endo illumination. The only care that needs to be taken is that the moment we remove the trocar out, I mean the trocar out, if we straight away put the endo illuminator straight away without wasting much time, there is not much time left for that oil meniscus to come out, because oil to come out, because oil is any which way is viscous. It takes it takes a few seconds to come out. So if we straight away put, for that you have to have a vigilant assistant, of course, but if you can manage to do that, we will also be able to prevent the oil leak that you were mentioning.
Yeah, but can you have a chandelier, because chandelier assisted buckling is anyway now, if you have access to chandelier, it would be easy for you.
Ma'am, agreed. But we any which ways need that visualization just for the localization and cryo of the break. So once we are done with that, we really don't have any use of endo illumination after that.
Good. Excellent video. Excellent.
Thank you, ma'am.
So we invite comments or questions from the other judges or the chairperson, Dr. Lalit Verma.
Yeah, you see, Vibhuti, how are you?
Good evening, sir.
This was an excellent depiction of the case. You see, sometimes we do surgeries to, depict an alternate modality. Honestly speaking, if it was a resurgery, in primary surgery, I would have placed an encircling band. But in a resurgery where the break is visible, I would have done a simple job of actually just aspirating with the active back flush, because I know the cause. The cause is there. The hole is there. It's either a missed or a newly formed hole, and it's a localized inferotemporal RD. I actually would not have, in the resurgery ventured to, open it up and do it, because the break is visible. I'll just go there and do extensive laser around it.
Sir, but
that's an alternate. We should not question the judgment of what you have done. It's very nicely depicted. One point is that, I'm not a very fond this thing of cryopexy. So excellent depiction, but cryo to me was slightly on the heavier side. You see, for a small hole, honestly speaking, just to make it look very, contrast and make us feel good that acha cry ho gaya hai. So I would do a small laser there. And other thing is that why should silicone oil be inside now? You see, the thing is silicone oil in inferior RD does not serve much purpose. Okay. And you are depending on oil inside now and buccal outside also now. Okay. So what I would have done in this patient is that I would have just active aspiration and laser around it. 10 minutes.
Sir, actually, to answer your question, I mean, I would have actually gone with the same thing, but the problem was that the break was not visualized. So it was.
We don't go with the preset mind. In resurgeries, we don't go with the preset mind that I have to do this and I have to do this. So we open, see, in case break is visible, because it's a localized. You would presume that because rest of 3/4 of the retina is attached, so only in that area, presumably break will be there. But in any case, we will discuss this over phone sometimes, but excellent depiction of surgery and a new modality, which is you have told us about EASB. I am very impressed with your video. Thank you.
Thank you very much, sir. I think great job, Dr. Kashyap. You impressed Dr. Lalit Verma, I guess. We'll move on back to Dr. Kudlu.
Thank you so much, Somshila. I think let's go on to the next presenter, Dr. Himadri Chowdhury. To introduce him, I request my friend, Dynamic Scientific Committee member, Dr. Amit Porwal. Amit, unmute.
Thank you, KP. Somshila, can we have the slide of Himadri? Yeah. So it's a pleasure to introduce Himadri. He was associated with us during the ARC programs also. So Himadri has basically done his fellowship on vitro retina from Adi Prasad. He is basically working as a consultant in vitro retina at Chaudhary Eye Hospital and Research Center at Silchar, Assam. He has been awarded with multiple medals and he's presented at various national forums. He's got more than 10 publications in various journals. So over to you, Himadri. All the best.
Good evening, everyone. Should I start sharing?
Yeah, sure.
Is it visible?
Yes, it's visible.
Okay, I'll start. I'll be presenting macular hole dynamic difficulty modulation. So macular holes are one of the commonest indications for vitrectomy. They are caused by tangential and anterior posterior traction of the vitreous on the surface of the retina. They are treated using vitrectomy, ILM peeling, along with a gas injection. However, not all holes are the same, and we might have to modify our technique. Now let us move with the basic ones. This is a small macular hole without any other antecedent problems. We start with a PVD induction first, and then vitrectomy is done. ILM is stained using brilliant blue G under infusion. Then peeling is started with a pinch peel technique. We peel all around the macula. We tend to prefer a larger peel from arcade to arcade. And once we are satisfied with the peel, we inject gas. And these patients do fairly well. Moving on to more difficult cases, I call them intermediate level. This is a patient with PDR with a full thickness macular hole, along with a localized retinal detachment at the seen on OCT. So here, removing the vitreous in the correct plane is very important. And using just the cutter, the plane might not be very easily visible. So we use a very simple instrument. This is a bent needle, which we'll be using. And using a bent needle, we can actually lift the posterior hyaloid very easily. Once the posterior hyaloid is delineated and lifted properly, the rest of the vitrectomy becomes very easy. Here again, we stain under air for a better staining. Also, the peeling is slightly more challenging in this case because this is a diabetic patient with a localized retinal detachment. Also, the ILM tends to break off every time we start peeling. So we might have to grasp and re-grasp multiple times. Once the peeling is complete, we move ahead with the panretinal photocoagulation. And in this patient, we injected silicone oil. So the patient did fairly well. 2 weeks later, the macular hole had closed, although there was some subretinal fluid still remaining. We finally move on to the most difficult cases. I call them advanced. This is a full thickness macular hole in a patient with total retinal detachment with multiple breaks. So here, removing all the peripheral vitreous is very important. We take the help of triamcinolone acetonide, chandelier illumination, and indent ourselves. Next, we check out the macular hole. Instead of using the conventional method of dyeing first, we first use PFCL to stabilize the posterior pole. Next, the dye is injected directly inside the bubble. As you can see over here, we are injecting the dye directly inside the PFCL bubble on top of the retina. So this is a small cartoon to depict what we are doing here. We first inject the PFCL, then the dye is injected inside the bubble. So the PFCL provides stability to the retina. It prevents any retinal toxicity because the dye cannot go subretinal. Also, it saves time because we need not wait for the dye to act. We can start peeling directly. Again, this was an old case with a large hole. So we went for the inverted ILM peel technique with the ILM tuck. So the ILM is peeled all around under the PFCL. And once the tucking procedure is complete, we go ahead with the rest of the surgery. That is, we do the subretinal fluid drainage and laser for the breaks. Again, we prefer silicone oil in a patient like this. And this patient also did fairly well. 1 month after surgery, the macular hole was closed and the retina was attached. So to conclude, all macular holes are not the same. We have to modify our technique according to complexity, and challenging cases can also be handled successfully. Thank you.
Thank you, Dr. Himadri. I think the very interesting case to discuss this particular case, we have got two senior vitreoretina surgeon, none other than one is Dr. Kim Ramaswamy and Dr. Chaitra Jaydev. So comments from Dr. Kim, sir.
Thank you, Dr. Himadri. There was an excellent video that you showed, and you clearly brought out the different challenges in the macular hole. Of course, most of us face the first one that you presented. The second one, the intermediate one, is definitely wouldn't come under as a macular hole per se. It is more of a tractional RD, and the whole outcome depends on how you manage the rest of the retinal tractions and stuff like that. The third part, of course, the macular hole in an RD, in a simple RD, I don't think it's as difficult as you would have it in a myopic retinal detachment. That I would call it as the most challenging type of macular hole surgery associated with RD. And it's nice to see that the technique that you're using for using PFCL, which we've been using this regularly. In all our macular holes, we tend to use that whenever PFCL is used, using the dye under the PFCL. I think that definitely showed, and your video was definitely excellent video. So I congratulate you on that. But I just wanted to understand what was the uniqueness in this thing, in the sense like you brought 3 different situations of macular hole surgeries. Could you describe on that?
Yes, so actually the title of my presentation is Dynamic Difficulty Modulation. This is something which is used in gaming terms. In video games, the gamers tend to have greater skills as they move on to the higher levels. So this is what I was actually trying to depict, that macular holes come in multiple levels. And once you go on doing them, you have to acquire further and further skills to do more challenging cases.
That's right. Yeah.
Thank you.
I'll pass it on to Chaitra.
Chaitra.
Hi, Himadri. I think that was a nice, presentation in the sense that you could put together different difficulty levels, especially for a beginner, to understand how to go in a stepwise manner. My concerns were actually regarding the second case wherein there was a TRD, though the surgery appeared very easy because first of all, the tractional component was not really too severe. We see much worse, and so it was presented in a very simplified manner, which is probably okay for somebody who has some expertise in operating TRDs with macular holes. But it is not always easy, as you know, to pick up the hyaloid and pull it off. It can cause more harm than good.
Yes.
We will be causing more breaks than we had started off with. So I think there the take home has to be a little more different, in the sense that these are challenging because we're facing not only a macular issue but also a tractional component, and it's not as easy as it was shown to be. So maybe some more pointers there when you next present a video, as a nice way to show this case would be the challenges that you face dealing with macular holes in patients with TRDs. So that is something that you should probably bring across. As far as the first case and the third case goes, I think those are fairly routine. Most of us are doing inverted flap for large holes and using PFCL in patients with Regardi. So I think that is something that you should probably focus on, macular holes and TRDs. That's about it from my end.
Thank you, Chaitra. I think any other comments from any seniors? Dr. Lalit Verma, sir?
Sir, you're muted, sir.
Sorry, excellent, Himadri. I would have done the same in all three patients, except that, as Kim said, I would add one more that is extremely difficult, is myopic macula. That's all. Otherwise, three patients you did was excellent, and I would have done this, absolutely, I would have done the same. But add one high myopic atrophic macula, which is a greater challenge, as Kim said.
So would you like to just say the challenges? Would you just like to tell us what would be your challenge when you're doing myopic?
The myopic macula, if there is a staphyloma there.
So let him answer.
Yeah,
let him answer.
Okay. Sorry.
Yeah, let him answer, because we've just given comments. Maybe we should ask him at least one question. So Himadri, what are your challenges for myopic macular hole?
Yeah, so first of all, the instrument doesn't reach the macula when you're doing with a very high macula with a posterior staphyloma. Yeah. So either you need specialized instruments for that, or you need to remove the trocar. And that way, if you're just using without the trocar, then the instrument does reach. And of course, these patients are the most difficult ones. And peeling also is very difficult, because if there is a choroidal atrophy underneath, even visualization of the ILM becomes more difficult. Of course, if a macular buckle can be used, that would be the best, but I do not have any experience with using macular buckles.
Yeah. Thank you so much for the judges. I think it was a very interesting discussion. I think over to Dr. Somshila.
Thank you again, once again, Dr. Kudlu. We move on to the next presenter. The next presenter is Dr. Meha Kanta. Can I request the others to keep the mic off, please? There's some background noise from somebody. Sorry. Thanks.
Can you mute?
To introduce Dr. Meha Kanta, we have our dynamic scientific committee member, Dr. Jatinder Singh Bala.
Yeah. Thank you, Dr. Somshila. Can you project the slide of Dr. Meha?
Yes.
Yeah.
Yeah. Just before Jatinder, just 1 minute. I'll just request our judges to check on their Google Mark sheet. All our judges are to mark all our presenters. So I'm sure that everybody is having, no problem marking. And if there is any problem marking, please, you can revert to Mr. Sai Krishnan. I'll just put Mr. Sai Krishnan's telephone number on the group. So I hope if there is any problem about the marking, then you can talk to Mr. Sai Krishnan. He will help to solve it. Thank you. Go ahead, Bhala.
Yeah. It's my pleasant duty to invite Dr. Meha Kanta. She did her MS Ophthalmology from Calcutta Medical College and long-term fellowship in surgical vitreoretina from Dr. Shroff Charitable Eye Hospital, New Delhi. She is working right now at Disha Eye Hospital, Barakpur, Calcutta, as a vitreoretinal consultant for a period of 2 years. And since last 3 years, she is also practicing as an independent vitreoretina consultant at Renu Eye Care in Patna. Over to you, Dr. Meha, and all the very best.
Thank you, sir. Good evening, everyone. I guess the photos have been exchanged. My photo has been put on somebody else's slide, and
I'm sorry about that.
Yeah, that's
sorry
okay.
about that. I was trying to match it to the photograph.
That's okay. Thank you so much, sir. Good evening, everyone. I'll just share my slides.
Doctor, may I have just press function F5?
Pardon, sir?
Just press function F5.
F5 Maya.
F5. 1 second.
F5 for function F5.
Okay.
Yes.
Your time starts now.
So diabetic macular edema, as we all know, is the most common cause of vision loss in diabetic retinopathy. With the emergence of high-resolution OCTs, now we are able to see adverse morphological effects on OCT much before we can appreciate them clinically. So we all know biomarkers are entities which help us to improve the understanding of a disease, prognosticate them better, and also help to treat the entities more effectively. There are various previously well-known DME OCT biomarkers, like there's the presence of drill, hyperreflective foci. We know about the ISOS junction disruption, ellipsoid zone disjunctions, and the presence of SRF. These are all known and well-documented OCT biomarkers. But today in my presentation, I would like to report a new OCT finding, intraretinal hyperreflective material seen in a cystoid space in patients with diabetic macular edema, as you can see in this image. So this hyperreflective material, which I observed, was placed intraretinally as clumps. They were present in a cystoid space. There was no shadowing. You can say it's a distinct entity separate from intraretinal hyperreflective dots or hard exudates, about which we previously have been knowing. I've observed a total of 15 eyes in my practice with this presence of this intraretinal hyperreflective material. So interesting about these cases were most of these patients had a visual acuity at their presentation, which was much worse when you correlated it with their clinical picture. Apart from the presence of this hyperreflective material, common associations, other common OCT associations were presence of external limiting membrane layer defects, ellipsoid zone defects. Some of them also had interretinal hyperreflective spots. A very interesting finding which I saw in 3 of my 15 patients was the presence of a large microaneurysm adjacent to the cystoid space containing the hyperreflective material. These patients were treated with intravitreal anti-VEGF injections with or without intravitreal steroids. So this is an interesting case in which I can actually show you the course and evolution of this hyperreflective material. You can see the patient presented with no diabetic macular edema initially, just moderate NPDR. After 6 months, when he came up, you can see the hyperreflective material developing in a cystoid space. The patient's vision had deteriorated. After 3 interventional anti-VEGF injections, you see the material is still persisting. Vision has not improved much, but the cystoid space has started to resolve. At this juncture, an Orthodex implant was given. At his final follow-up, we saw vision of 612, with the cystoid space much reduced, and the hyperreflective material, though persistent, was seen to be resolving. Here's another case in which the patient presented with a 624 visual acuity in the presence of this hyperreflective material in the cystoid space. During the course of treatment, he received 4 intravitreal anti-VEGF injections and 2 intravitreal steroid injections, but the hyperreflective material persisted, and there was not much improvement in his visual acuity. This is another case which I like to present in which you see the patient came to us with cystoid macular edema. He was advised treatment, but he was lost to follow-up. After 8 months, he came back to us with this picture in which you can see this peculiar hyperreflective material developing. Interesting, in this case, you can see an ovoid-shaped large microaneurysm just adjacent to the cystic space. So in all the 15 patients which I observed, the common things were that they presented with a visual acuity which was much worse when you tried to correlate it with their clinical picture. The number of intravitreal injections we had to give for the resolution of the edema were much more, and the response was not very good. The final acuity which we achieved was also not as good as compared to other forms of diabetic macular edema, and resolution of the material was not achieved in most of the cases. Therefore, we can safely say that hyperreflective material is an indicator of poor prognosis. The pathogenesis, this may be considered to be an inflammatory debris because of the breakdown of the inner and outer retinal barriers, and the presence of the microaneurysm in some cases may be suggestive of persistent leakage. So I'd like to conclude that this is a new finding, a new entity, which can be considered as a potential novel OCT biomarker to predict the treatment outcome in diabetic macular edema eyes. Presence of this marker can help us to formulate a treatment plan as to how much to treat, when to stop, when to unnecessarily stop interventions. So if we are able to identify a prognostic marker, then we can help to set realistic targets for both the clinician and most importantly for the patient. Thank you.
So the lead judges for this contestant are Dr. Dogra again and Dr. Cheta Debe.
I must congratulate you for this good presentation, but I have few things which I would like you to clarify here.
Yes, sir.
most of the foci which you have shown were showing somehow as if they depicted hard exudates, because they were sort of everywhere. I could see that there was hyporeflection following and going down. So that is one. And that is, I would like you to clarify that. And second point, I think initially you mentioned ISOS junction, uh, and subsequently you mentioned ellipsoid zone. I think you should be very clear at this time that mostly we are not using ISOS now, no more. It is the ellipsoid is same. So they are absolutely synonymous. Rather, you only use is ellipsoid zone, because mostly from most of the now recent context, ISOS junction has gone out and ellipsoid zone is in. And another thing which you have not picked up, which is considered as important again inflammatory biomarker, you didn't even emphasize, is you had in two of your cases subretinal sort of a fluid, and which is another one which is considered as a very important. At least you need to kind of make a mention of that, because these are two very important inflammatory biomarker reported in many studies now and are almost like established. So I would like you to answer some of
I'll
these
answer them
queries.
one by one. First, so they were clinically, there were no hard exudates in the area from where this has been taken. There was no back shadowing in the OCT. There's hyperreflectivity.
I think I see that back shadowing in every case of yours. That is what. So be careful about that, because these are tiny, less than 30 micron. You see, you have to be very careful. And I saw that back shadowing everywhere. That is where the problem is. So I think be careful about that part, and you can look at that very carefully. Everywhere you have a streak going down of back shadowing.
So there were presence of hard exudates, but the area where the scan has been taken, the area of the foci are, they're like hyperreflective foci, which are less than 30 micron. So this may be, in the assumption, the material may be a coalition of these hard exudates. It may be inflammatory and debris. I don't know, speculating what this material can be. It's a new finding. Mostly this has not been reported also in literature. Hyperreflective foci, as you said, subretinal fluid is a new OCT marker. It has been shown to be a good OCT marker. Presence of early SRF shows good resolution. So that was there, I not mentioned, but I mentioned as it already a known SRF being a known OCT marker. And so you're right, ISOS junction is not used because ellipsoid zone is now considered to be just the outer portion of the inner segment where the mitochondria exist. So ellipsoid zone is actually a different entity from ISOS, because we're just talking about the active part of the area where the mitochondria exist, where all the energy of the rods and cones are existing. So either we use so the ellipsoid zone. So you're right about that, but they're two different, because they were talking about the junction between inner segments and outer segments. Here we're just talking about the outer portion of the inner segment containing the mitochondria. That's what I understand by the ellipsoid zone. So it's a different term than ISOS, but ISOS is not used anymore because we're talking about integrity of the ellipsoid zone as a outer retinal function. So there you're right. And so subretinal fluid was there, but that was a known OCT marker. My point was to show a no OCT marker, which is not.
My question here is that this is also an inflammatory biomarker.
That's
Most
right.
of the time it may be associated, and they both, you see, what you have already presumed that perhaps they would be better off with giving intravitreal steroids, because the same thing is happening, and there are many studies recently you can find. So I think with this, I'll go on to Dr. Chetra. She could please, Dr. Chetra, come in and you can.
Hi, Meha. Interesting presentation. So my concerns regarding this observation that you have made is, I think we are all seeing it in our practice. But we've, kind of been able to deal with it because we have to take all other features of that patient. Okay, what is the proliferation? What are the other findings? What are the other biomarkers? OCT biomarkers itself, if you know, we don't take any biomarker independently. We take the whole picture. So from your recommendation on your final slide, the second recommendation that you said is this is going to help me decide how much to treat, with what to treat, and how long. So tell me simple, based on your finding, I'm saying it's an interesting finding and we've been seeing it on OCT. What is your recommendation?
No, I was trying to report this as a potential biomarker. At this juncture, I cannot come to this conclusion because, as I said in my last slide, which is not show, that I've not even compared that individual VEGFs work better or steroids work better. What is the status of the patient, the glycemic status of the patient? Angiograms have not been done. So so many things.
So it is a little premature. It's a little premature.
Writing and observations have been seen, but you're right. A lot of things have to be studied, like an angiogram, what injections work better, anti-VEGF for the inflammatory pathway, because there's so many pathways which are involved in it. And
yes. Second question, Neha, second question is, you said that the visual acuity in these patients, you had 15 patients, right, was much lesser compared to other patients. Now, how many patients did you compare with? And in what way were they comparable? See, if did they have all other features except this, intracystic hyperreflectivity? See, you have to compare head to head, right? To say that the visual acuity. Now, the patient's visual acuity in your group could have been less just because of the subretinal fluid. It could be ischemia. There are multiple factors why visual acuity could have been less. So you tell me, how did you compare to say that the visual acuity was lesser in these patients to start off with?
No, my comparative point was just most of these patients had moderate to severe NPDR, no proliferative changes. And angiograms I had over a few cases which were basically similar with just leaking microaneurysms and generally no ischemic changes. I didn't have all the patients, but around 7 patients had angiographic pictures. So, but it's not a head-to-head comparison. But the clinical picture looked better, and the patient used to see worse. You should expect more. It was just a basic observation that you're seeing more, but this hyperreflective material being present, the vision was not much at presentation, did not improve much after intravitreal injections also. So it was just a finding which I saw first time for around 15 patients. So I also want to now go into it and do these head-to-head studies, do angiograms, compare them with patients who don't have the material and see what treatment works better and what more we can look into, what are the more associated findings. Only interesting one was the large microaneurysm. That was something which I saw, that 3 of them had microaneurysms. So maybe it is the persistent leakage which may be causing it. So a lot to look into it yet. I was trying to report it as it may be a potential biomarker like DRIL, like subretinal fluid, and like hyperreflective foci, which we have already known as well-known robust biomarkers for adaptive macular edema. So
Neha, I think that because we're slightly running behind schedule now, so we'd like to move on to be fair to everyone. And I would just like to again correct by showing you a correct picture for a starter. And hand over to Dr. Bhalla. Are you taking over?
Yeah, ma'am.
Yes, please.
Now, it's my pleasant duty to invite our dynamic scientific committee member, Dr. Feroz, to please invite the next speaker, Dr. Nilesh Kumar, to give his talk on smartphone-based gonio imaging. Over to you, Dr. Feroz. Dr. Feroz, are you there?
Thank you, Dr. Bhalla.
Yeah.
Yes. Thank you, Dr. Bhalla, and good evening to everyone. So it's my pleasure to introduce Dr. Nilesh Kumar, who's a very young innovator, a final year DNB resident who has already made his mark in academics and research. So welcome, Dr. Kumar, and all the very best to you. Go ahead presenting your innovation to us. Thank you.
Thank you. Thank you so much, ma'am. So I'll just share my screen. Good evening, everyone. I would like to thank AIOC and viewers for providing me an opportunity to present my work, Smartphone-Based Gonio Imaging, the present and the future. I'm Dr. Nilesh Kumar, and these are my disclosures. Gonioscopy is not performed as frequently as it should be. 83% of the junior residents are not confident doing it, and half of the patients that visit a glaucoma clinic do not get a baseline evaluation done. Despite being such a vital part of glaucoma diagnosis, I feel the lacunae is due to the enigma of the skill itself, its dependency on the slit lamp, the chair time it takes during a busy OPD, and lack of quality trainers. So when we started searching for an alternative to the gonioscopy, it was this 20 lakh machine just to take a gonio image, or a sophisticated software to do a 3D reconstruction of anterior segment OCT. All these are not viable in a resource-sensitive country like ours, the point which we raised in this letter to editor. But when asking question is important, finding solution also is. We innovated a novel technique using just a 4-mirror gonio lens and a smartphone, which was validated on 65 eyes and was published in Journal of Glaucoma. The cover art is the testament to the quality of the image that can be obtained. But as my mentor, Dr. Ashish Sharma, has told me repeatedly, no journey of an innovative idea is complete unless it is translated into a product that can be used by anyone, anywhere. So we developed a frugal, one-of-its-kind device, which is now 1 year into the patent process, compatible with all major type of gonio lenses and smartphone. We call it the DIGS Pro. And this is how the device works. We place the gonio lens in the adapter, which by design aligns centrally with the optics of the smartphone holding segment. The smartphone, which can be either Android or iPhone, is snapped fit. A normal camera app is to be used for clicking the image. The lens with the holder is applied in normal fashion under topical anesthesia. The patient is asked to look straight. The smartphone segment aligns beautifully with the lens adapter, and you just click using the camera flash. As simple as that. These are few sample images using four mirror lens, some 3 mirror lens images. So recently we concluded a larger validation trial for the device, where out of 280 images, 89% were of gradable quality. The kappa coefficient between the gold standard slit lamp gonioscopy and the device was 0.65, while between two masked graders was 0.82, both implying substantial agreement to classify open and closed angle. It is also a great patient education tool. Only 53% of the patients agree for AIOC PI when counseled verbally. But when we show the image using DIGS Pro, 86% agreed for the prophylactic laser. It takes approximately 4 patients to gain the skill. Optometrists and technicians can be trained very easily, and one thesis is underway to validate the device as community level. It can also double up as the diffuse anterior segment imaging device due to its inbuilt optics. An app is also in validation stage, which will not only make the record keeping easier, but will enable reports to be shared instantly for teleconsultation, and will also give us an opportunity to collaborate for various research projects. One such project is to create a data repository using DIGS Pro images, which will then be utilized by machine learning to create an AI overlay in the app itself, so that when a technician clicks an image somewhere in the periphery, the device instantly will tell that the patient needs a treatment or not. That's what we imagine our future to be. So keep imagining, keep innovating, keep translating, keep digging. Thank you.
I think the lead judges for the presentation of Nilesha, Dr. S.S. Pandav and Dr. Shriya Thate. Dr. S.S. Pandav, sir, for your valuable comments.
I think that's, first of all, I must congratulate the inventor. I think this is an area which is, there is an area of need, I would say. The gonioscopy is something which is very often missed from the clinical evaluation and which is very important from glaucoma diagnosis point of view. The reasons are varied. Maybe I think he did mention, many of them. But essentially because this needs experience to interpret the images, the gonioscopy in the clinic. And if you have and still at best it remains, somewhat subjective. So it's very hard to kind of translate from one observer to another observer. So I think if you have an image which can be interpreted, which can be seen by different people, and that more or less there are more chances that would be seen in the same light. So that I think is a very good innovation, and I must congratulate the inventor for this. Having said that, some of the things that would I'd like to know is number one is basically because the interpretation finally would depend on how well you see in the angle, how good the image is. So the image quality is of utmost importance, and whether for an open angle it might be okay. Is it a way to change the magnification, or you get the desired magnification? That's number one. And number two would be in angle closure, because this is the most important in angle closure. This disease basically where we want to not to miss angle closure glaucoma. And in that situation, sometimes you may not actually get the angles readily unless you do some manipulation of the eye during gonioscopy or do an indentation kind of a gonioscopy. So my question would be, can you do with this technique, can you do that indentation and some manipulation of the angles while you're taking the pictures?
Yes, sir. So, sir, I will like to answer the both questions. First is we can do indentation gonioscopy, sir. We can do easily with the video mode. Like we are using still mode now to take the image. But if we go into a video mode, then we can indent the image. We can indent the cornea with a 4 mirror lens. in the same device, same settings. We just go from the still mode to a video mode, and there, if we do, we can do the dynamic gonioscopy. And even if we use the slow motion camera, which comes inbuilt in all the smartphone right now, if we do the slow motion thing, we can easily get the changes. We can very easily dynamically see when it is recorded. So it is very easy for the patient also. Like once only you have to do the indentation, and then you can at leisure review the video and tell if there is a dynamic change happening or not. Due to paucity of time, I could not show, because what we had innovated was use of flash, like flash going off and on, so that the pupil constricts. So we get more physiological change of angle. So we use a slow motion camera and a flash that goes off and on. So it gives a more physiological response, the angle opens up or not. But due to paucity of time, I could not show. And so for the clarity of image, we in the validation trial, we used there was one study which was published in AIOC for the ROP images, how the blood vessels, how clearly they were seen. So same concept we used in our thing, and 90% of the images were gradable, like how well we could see the trabecular meshwork or the iris details. Based on that, we clarified the clarities.
I think the second question I was coming to was about the people basically, and you partly answered that. Because you are using flash, the people will get constricted, and the image you will get will be an artificially open angle, even if its angle is closed. So how do you control for that? Because a technique where you do not miss the angle closure.
Yes. So for last 1 year, since I innovated the device, for last 1 year, I am trying to find an answer to this, because this was the first question it comes. Everybody is like, you are using a flash, it will induce a pupillary constriction, and you won't. And just 2 months back, I could actually find an answer. There is a latency in pupil constriction. Once we show the light, it is 0.18 to 0.2 second in Indian population. That is fairly equal in young and old, same. So the flash which we use it takes it is shown only for 0.05 seconds. And the average I took for all the images, like last 100 images what I had taken, and the shutter speed of the camera was 1/100th of second. That was 0.01. So it was total 0.06 second to take the image, and the latency was 0.18. So it was like three times we had the space, the privilege we had to take the image. So theoretically, yes, it can induce, but practically, when I did the math, I think it was not. And that's why, sir, we had a good substantial agreement between slit lamp and the device.
I think you did mention about the latency in constriction, but also there would be a latency in fully dilating the pupil. So because if you are timing your flash in a way that pupil has not actually gone back to its original dilated position in the dark room, because it takes time for the people to go back to that position. So I think you have to keep that also in mind when you're
Just now, 2 months back, I could, and because of COVID, I could not actually validate the whole data set. But that is the next part, because that is one question that comes everyone who sees the device, they are like asking this question first.
Yeah, I think that's a great innovation, and thank you very much for sharing it with us. I think that's all from my side.
Thank you so much, sir.
Thank you. Yeah, Dr. Nilesh, I must congratulate you for the very innovative technique. I have just one question. I think Dr. Pandav has already asked you the questions and you have clarified them. The only one question is that you are using both the hands. One hand you are holding the gonio lens, and other hand you are pressing the camera. Is it, and that too with standing position? Is it not very difficult to hold and do that?
No, ma'am. It is. I showed it in standing position, but even if the patient is lying down or we are sitting in, I usually perform with me sitting on the surgeon's chair and the patient in the refraction units, ma'am. So it can be performed anywhere. I have a photograph where I have shown it being done in patient lying down condition, in camps also, where there is nothing. Like the patient is sitting on a bench, I am sitting on a bench and doing it.
Okay. That's from my side. Congratulations.
Thank you, ma'am. Thank you so much.
Any quick question or comment from anybody from the judges?
I think we are halfway through, and 5 presentations have gone by, and the judges have asked phenomenal questions. We are seeing wonderful innovations and wonderful presentations, videos, really. And, it just brings to my mind 2 things. One is a very nice quote that I always remember. talent is a gift from God. But what you do with the talent is your gift to God. I think this is a very important thing. And these young talents from all over the states are doing a great gift back to God. And here again, I must say that Intas Pharma have been very, very supportive in our talent search programs. And they are the ones who are sponsoring this, and without much financial interest at all. So kudos to them, and thanks to them from the whole scientific committee AIOS. Carry on, Somshala.
Nilesh, I had a question for you.
Yes,
How
sir.
do you control the room illumination when you're doing the gonioscope?
I usually do not switch off the lights completely because it hampers with the autofocusing. So some light needs to be on, but it should not be above the patient head. So usually the door light I keep on. So near the door we have a light in the OPD. So we keep that on so that autofocusing is...
That light also is going to affect the angle opening.
Yes, sir, but
As Dr.
usually...
Panda was telling about the angle closure, there's a major, if some solution can be sought for this,
Yes,
it's
sir.
a great breakthrough. It's a great breakthrough.
Yes, sir. So if we can switch all the lights off, sir, and do that gonioscopy, it won't affect the results at all. It is just the matter of convenience. Like even in OPD, we do slit lamp gonioscopy with some light on sometimes. So
Are you marketing? Are you marketing this?
Yes, sir. We are commercially marketing.
What's the cost of this? You're charging for this?
25,000 rupees, sir, without the gonio.
Okay, thank you.
Thank you, sir.
Thank you very much, Nilesh.
Thank you, ma'am.
I think we'll, interest of time again, go to the next presenter. Nilesh, are you sure that was your photograph? Because you look very different now. But, but the next presenter is another young lady and will be introduced by my friend and a scientific committee member, Dr. Parikshit Gogte.
Thank you, Doctor. It's a great pleasure to introduce Dr. Reena Sorokhaibam from Manipur. I hope I've got her pronunciation correct. Manipur is a very small state, but she has done great work there in infective uveitis in the OPD. She's currently pursuing her fellowship in UV and medical retina at Shankar Netralaya, Chennai. But she's had a very glorious career during her MBBS when she has been a topper and also in MS ophthalmology. So over to you, Dr. Reena.
Good afternoon, everyone. I'll be presenting on infectious uveitis in an IMCD in Manipur, a case series. Manipur is a small state in the far northeast corner of India with a small population. It is well known for its natural beauty. However, lately now it is becoming known for its high prevalence rate of HIV, and therefore it is very apt that I begin this presentation with a case of atypical cytomegalovirus retinitis in a HIV patient. A 17-year-old boy presented with reduced vision and floaters for 1 month in both eyes. He had tested HIV positive, but he was not on ART medication. The BCVA was 6/9 in both eyes, and on contact examination, a dense whitish retinal lesion in the peripheral retina was seen. CD4 count was 176 cells per cubic millimeter, and the differential diagnosis of this lesion was infective uveitis. CMV retinitis came first, then bacterial fungal infection, toxoplasmosis, granuloma, etc. Considering the fundoscopic finding and the HIV status of the patient, the initial treatment given was oral steroids and ART. 3 months later, the patient came back with a picture showing fulminant CMV retinitis involving optic disc in both the eyes, and vision had dropped to fountain figure. The treatment was revised, and specific anti-CMV medication, injection ganciclovir and tablet ganciclovir was started along with the ART. This slide shows the treatment response of the eye to the anti-retroviral therapy and the CMV retinitis therapy. There was, after 9 months of therapy, there was hemorrhage and exudation disappearing, and the vision improved to 6/26. Next, we have a case of TB, tubercular uveitis. 30-year-old female presenting with illness of vision in both eyes. On examination, there was anterior synetia and as well as motor venous exudates in the both the eyes, and there was choroidal granuloma seen in the left eye with ERM. This shows a picture of the anterior uveitis with mutton fat capes and broad-based posterior synetia and peripheral anterior synetia. On investigation, the Montu's case was strongly positive with necrotic reaction. The diagnosis of pen uveitis in both the eyes was made. And next case, 56-year-old female of only 34 kg weight, non-diabetic, non-hypertensive, presented with dimness of vision in the right eye. And on examination, the fundus showed vitritis and active choroiditis lesion. Montu's test was positive also in this case. On fundus examination, we can see an active choroiditis at the inferior nasal part of the macula. HT was started, and on the follow-up after 40 days, the lesion had decreased in size. Next case, it is a case of ocular toxoplasmosis. A 17-year-old male presenting with dimness of vision in the right eye with a vision of 6/36. On examination, there was macular exudate with disc edema of the right eye. Toxoplasma antibodies were positive both for IgG and IgM. Treatment was started for anti-toxoplasmosis. Spectrum DS, azithromycin, and visolone were given. The last visit, the vision had improved to 6/12. Thank you.
Thank you very much for a really interesting series of cases. The discussants for your presentation are Dr. Malika Goel and Dr. Shreya Tate. Dr. Malika Goel.
Yeah, I'm here. Yeah, very good cases, doctor, very nicely depicted. I thought your topic was more on what is the profile of patients of infectious uveitis in Northeast India, but what you have shown is 4 cases. So let's discuss what you have shown instead of the pattern of infectious uveitis. The first case, you showed some retinal lesions.
Yes,
and what was your diagnosis for those?
The first case was the CMV retinitis case, ma'am.
Yeah, so you made a diagnosis of CMV, but you did not start anti-CMV, you started ART.
Yes, ma'am. Actually, the first presentation was with only a peripheral lesion in the right eye. So we started only with ART.
Yeah, but it was a very large lesion. Peripheral doesn't mean it was small. It was occupying a large area. So in any case of extensive CMV retinitis, I think you also need to start CMV, anti-CMV. In fact, probably it's even better to start only CMV treatment and then start ART much later when the CMV is controlled, because you do expect a worsening of the inflammation if you start ART at the same time, which is what you saw. Once you started ART, you had a very severe CMV retinitis. So I think you have to start CMV treatment. Just like in an HIV patient, if you have tubercular lesions, you have to first start anti-TB. In fact, ART comes much later because you do not want a paradoxical worsening, right? But your result was very good. Finally, the patient did very well. The second 2 cases which you showed were tubercular. The first one is, I think, an immune response to TB. It's an immune response to TB. Whereas the second one was actually, I think, the bacteria in the eye, actual live tuberculosis in the eye. In any case, both do need anti-TB treatment. But in the second case, you cannot give steroids. You should not give steroids. If it responds to anti-TB treatment, that's it. That's alone, because you might make it much worse with steroid treatment. Whereas in the first case, steroid also is a sheet anchor with the. So I think you would agree with that, or do you have something to add?
Ma'am, in the first case, when the patient presented with the lesion, we did not diagnose it as CMV. That was why we did not we did not start the anti-CMV therapy, cancer ovarian. But when the patient presented again after 3 months with a picture just like a permanent CMV retinitis, then only we started the CMV therapy. So actually, we missed the diagnosis and the first when the patient came first. And then in the two cases of tuberculosis, the first patient, there was a panuveitis presentation with anterior segment involvement, posterior segment involvement. Therefore, we started both steroid as well as ATT in that patient. However, in the second tubercular patient, there was only a choroiditis lesion. However, the patient was severely underweight, with presenting only with 34 kg body weight and 1-2 positive. So we started it on her own ATT, but steroid we added later.
Yeah, so I agree with you. In fact, when the first tubercular case which you have, you can even sometimes you may require to add alternative immunosuppression like azathioprine or methotrexate in addition to steroids, because some of these are really recalcitrant to treatment. So this just to make a differentiation between types of tubercular association in the eye and how to address the treatment. And in the fourth case, of course, it was a very classical toxoplasma. I just wanted to say that the role of ELISA, toxo, IgG, IgM is really very doubtful. They can be negative and still you could have toxo. So I think most of the time we have to go with only our clinical judgment. And the only other good differential to toxo could be candida, endogenous candida. So that's all. These are my points. Good cases.
It was nice presentation of varied etiology of uveitis. And many times it is very difficult to actually reach to the etiology of the uveitis. So in first case, initially you said you missed the diagnosis, but how you proceed for this when you saw that lesion in the posterior segment and all, what are the investigations you did? And even 2 cases of tuberculosis also. So how you started this entity, how you proceed actually in case of uveitis to reach this etiology, because if you treat the etiology, then only you will get the response. So in first case, can you just explain these things?
Ma'am, in the first case, patient was already a HIV positive patient. The history was very significant. So we had to look for opportunistic infection in the HIV patient in the first case. So along with the typical picture of the CMV retinitis, we had to start the anti-CMV therapy. And then
in tubercular cases also these two, you have anterior uveitis also in one case. So how you, because there may be any etiologies, how you proceed to get the diagnosis? What investigations?
We did the basic investigations first with complete blood count and 1-2 chest X-ray, and when to rule out any viral infection also, we did the hepatitis and herpes investigations, but we were not able to send for any PCR because that was not available at our setting. And however, since the 1-2 test was positive, we went further for HRCT. HRCT findings was positive in one case, but there was no finding in the second case.
They were not known case of tuberculosis?
No, there were not known cases of tuberculosis.
Right. Okay. Thank you.
Any quick comments, Chaitra, Dr. Chaitra?
I think it was interesting, and I'm not too much of a uvea practitioner, so I think Malika had valid questions. I'm good, sir.
If I have to just add a comment, the treatment of toxo could be much more easily done with intravitreal clindamycin now, rather than giving these toxic drugs for 6 weeks. So you just give 1 or 2 injections and patient is all right. So that's one thing that could be added. In tubercular cases where you are giving anti-TB treatment, we have to caution the patient many times to report any vision drop, because the ethambutol and INH, which is given by the physicians, now patient will think it is because of their original uveitis, and even we may think that the original uveitis is the cause. But I've had patients of uveitis on ATT who have noted a sudden drop in vision, where I had to suddenly change the anti-tubercular medication. So we have to keep on emphasizing to them, please report any drop. And we also have to take it seriously when we see some drop, and then change the medication.
When you have a non-inflammatory loss in vision, drop in vision bilateral, and the patient is on these drugs, so it should be very importantly.
Very difficult to make out which one is the cause, but if you see a deterioration in vision, which you would not expect if a patient is being treated, you don't expect them to suddenly drop vision, then you have to suspect it is drug-induced.
Thank you. I think that, again, with my obsession for time, so we want to move on to the next talk. Excellent discussion points, Dr. Goyal and Dr. Shreya. Dr. Bala, I hand over to you for the next speaker.
Yeah, I think we are having very nice galaxy of cases and very useful comments by our esteemed judges. Now it's my pleasant duty to invite my dear friend from AIOC Scientific Committee, Dr. Parikshit Gogate, to invite the next speaker, the young Turk from Tripura, Dr. Shyamrup Bhattacharjee. Dr. Parikshit, please.
Yeah, Dr. Shyamrup Bhattacharjee is a pass out from the Regional Institute, Tripura. So you are showing Dr. Sneha Batra's slide. Now this doctor.
Yeah, this one.
Sorry.
Yeah, and he's completed his MS from the Government Medical College there, the RIO, and is presently working in IGM Hospital, Agartala, Tripura. And he is going to speak on the retinal changes in hypertensive disorders in pregnancy. So we all remember doing the rounds of gynec wards for pre-eclampsia and eclampsia checkup past midnight. And the gynec people would always call us between 1 p.m. to 4 p.m. because they would say the ophthalmologists get to sleep, which we don't. So over to you, Dr. Bhattacharjee.
Good evening, all the respected viewers. I'll just share my screen. There appears to be some technical glitches.
Your screen is not sharing?
There appear to be some technical glitches, ma'am. I'm coming to that.
Please share screen. The green button 6 o'clock on your Zoom.
Shyamrup.
Yes, sir.
Sunilji will play your PPT from the background, and you can speak on the PPT. You don't need.
I think it's not available with Sunilji.
Okay. What is it?
May I ask Sunilji for some help? I'm not finding that prepared PPT in my screen.
Yeah, just give me a second, sir.
Okay.
I'm unable to find your PPT. Your name is not coming in PPT list.
Yeah, he has not shared it with you, Sunil.
No, I don't have his PPT.
That's right. Shyamrup, you're not.
Can I? No, ma'am. Can I bring from the?
Dr. Shyam, do you have your PPT with you?
Yes, I have.
Okay, just click on the green button. Sorry. So just click on the green button on the screen, which says share screen, bottom 6 o'clock on the Zoom window. And then share.
It's not coming here.
Okay. Let me see. Shyamrup.
Shall I go to documents?
Shyamrup, 1 minute, please. Shyamrup, what you do is mail the PPT to Mr. Sunil. Okay, and we will go to the next in order, and we will give you the next chance. Once Sunilji has your PPT in the
Okay, sure, sir. Sure, sir.
backup, then you can speak on the PPT.
Sure, sir. Okay, sir.
Dr. Shamram, I've sent you the message on chat.
Okay, Shamrup, you can mute yourself, and we can go to the order then.
I think the judges should note that we have to go to the next on the Google form, the judges, because we're all now we're marking for Shamrup. So we go to the next page and come back later for this presentation.
Amit, can they do that? Amit, you're aware?
Yeah, it's possible. It's possible.
I just thought I'll put that.
Yeah, thanks, Chetra, for that. So everybody, please note
I
that.
think Shamrup has not opened his presentation and minimized. If he does that, then once he goes to the share screen, the presentation will be visible.
Amit, let him mail it to Sunilji, and let's go to the next in order.
Yeah.
Then.
Everybody, please note that we're going to the next presenter, Dr. Sneha Batra, and Amit will be introducing Dr. Batra.
Yeah, so all the judges, you have to move your Google Forms to the next speaker, and that is Sneha Batra. So, Somshila, are you going to show the slide? Yeah. So, okay, it's Sneha's slide only. So, basically, it's my pleasure to introduce her. I've been knowing her since last 2-3 years. She's a very hardworking person, and she's working as a associate consultant in Trinetralaya and BPI Foundation VIP in Kolkata. She received numerous awards. As I told, she's already hardworking, so that's why she's got all these awards. She's written articles and publications. She's got publications. She's also the executive committee member of AIOC chapter of West Bengal, and she's of course a proud LD alumni member. Thank you, Sneha, and all yours.
Is it visible?
Yes, it is.
Sorry, I cannot see it on the full screen. Is
Dr.
it
Sneha,
visible?
put it in presentation here, please.
Full screen.
Yes, I've done that.
The presentation is frozen.
On the right-hand side.
Yeah.
Is that
Done.
okay?
Yeah.
Okay. So good evening, everyone. I will be presenting the findings of our study, the West Bengal Diabetic Retinopathy Project, Fixing the Missing Link. From becoming the topmost the affected country. And even though the prevalence of diabetic retinopathy is said to be lower in India than the other countries, it is the sheer number of people who have been affected by diabetes in the coming years. So 11 major epidemiological studies have been done, but 8 out of them have been done in the southern Indian population. Very limited literature is available in India. And in fact, till today, there has been no DR prevalence data from our state of West Bengal. So the primary objective of our study was to determine the prevalence of DR in the state and to find if there is any about our study was that the subject set was neither in the population nor was it taken from an eye clinic. The diabetologist or the treating physician arranged these camps at their own clinic. And this is the first time that a prevalence study of this kind has been conducted for DR in India. This is how the diabetologists conducted the camps in their clinics, and the ophthalmologist team visited only on the day of the camp. We included all patients with a known history of diabetes mellitus and excluded those with a media opacity. The counselor filled the pre-tested questionnaire. The on-field ophthalmologist recorded the DR grading with the help of an indirect ophthalmoscope. Statistical analysis was done with software R. 1,553 subjects were screened over 14 districts of West Bengal, maintaining a rural to urban ratio of 60:40. So the prevalence of DR in our state is 1%. But what was most shocking was the huge difference between the rural and urban population, which has never been seen in any other epidemiological study. The prevalence of DR went up with with the age of diabetes mellitus, but there was no difference between the genders. The control of diabetes mellitus was variable, and what was very interesting to note was that the simple question of whether someone knew that diabetes could cause blindness led to such a huge difference in their control of their systemic disease. What was very dismaying to note was that despite the fact that these patients were by a diabetologist, 33% remained unaware that diabetes could cause blindness in the eye. And this was even worse in the rural area, the ophthalmologists in our state. The awareness of diabetic blindness went from 60% to as high as 90% as the diabetic age went up, possibly after intervention by an ophthalmologist. The last eye checkup, in more than 54% cases, it was not done in the last 1 year, and in a substantial 19%, an eye checkup had never been done since diabetes was diagnosed, once again highlighting the missing link between the treating physicians and the ophthalmologists. The last eye checkup rates were better in the urban areas, and ultimately all this led to a loss of visual acuity, which again was worse in the rural area of diabetic retinopathy, which West Bengal is facing, and it is gradually shifting from the urban to rural areas. And this is important because these areas already have an unmet need for intra, and it could lead to a catastrophic increase in diabetic blindness. So what is the solution? We feel that this etiopathological chain can be broken only if the awareness of diabetic blindness can be increased in the young diabetic and the pre-diabetic age group. This is very important to note because in this young diabetic age group, the patient has still not contacted the ophthalmologist. Has to be done by the treating physician, and we have to realize that this is my conclusion, that the missing link can help us to win the war on diabetic retinopathy. Thank you.
Dr. Mangat, Professor Dogra.
Dr. Sneha, a very good idea to conduct this kind of study, in fact, with the physicians. Few things which you talk of a missing link between the ophthalmologist and physician. That part is not addressed at all in your study. In fact, it has not even been asked in your questionnaire. I think that should have been very important, because that is what would perhaps give us better, insight into whether they are being sent for examination or not. And another one which I would like to say, just doing an indirect ophthalmoscopy, the early diabetic retinopathy would be missed in many, because it's a small image, and that we know that is a problem. And the third thing which I want your clarification, you have first time shown that the rural population is having a very high prevalence as compared to the urban. And for that, I think nothing has been conclusively shown by you in your study. Was it like that they are not getting controlled at all? Did you do some investigation? You see, because once you have a data like this, which is so important, and first time you're talking, you need that kind of, going into that insight. So these are some of the things which I would like you to address for me.
Yes, sir. Thank you very much, sir. So the points that you have mentioned about the indirect to accept that that is not the correct way, but because we are taking it to the physician's clinic, we have to carry something which is portable. So the second thing that we added in this study, I could not clarify it in detail, was the addition of the fundus photographs, which were taken simultaneously for every patient with the help of a non-mydriatic fundus camera. And these photographs were then later analyzed by a retina specialist by bringing them back into the ophthalmologist's clinic. So even when there were some very mild DR cases, we could diagnose them, and even if they had been missed on the initial indirect ophthalmoscopy. And I think you talked about how the missing link was not addressed, sir. Yes. So what we realized that the referral rates were much better in the urban areas, and hence the compliance to the yearly checkup also, all these rates were much better in our urban areas. And as to how we differentiated the urban and rural areas, that is according to our West Bengal's municipal corporation. And again, as you mentioned, sir, this has never been seen in any other study before. We ourselves were very surprised when we saw the data, but we realized that because this is something which had been discussed in other studies, that this epidemic is going to shift, and the diabetes mellitus is now being better diagnosed and treated by the rural physicians as well. But the awareness and the requirement for eye checkup is not so much there. So probably that
That's
is
fine.
why
That's in
this
general
is
you're talking.
happening.
Once you do a study, you see, you form it a part of study. That's what I meant, even for a missing link as well as for the rural versus urban. I think Dr. Kim is here. He is. They have a lot of experience doing these kind of epidemiological studies. So I think I hand over it to Dr. Kim.
Thank you, sir. And thank you, Dr. Sneha, for that beautiful presentation. First, I want to understand when you call it as a prevalence data, this is definitely not a prevalence data. You have to understand you have done it in a physician's pooled population, which means the people who are coming to them are those who are seeking care and not the people who have not seeked care. So it's not even the urban and rural division you're talking about is not really the data that you can call it as a prevalence data. Because these are the people who are actually seeking care. So unless you did a door-to-door sampled population, you can't call this as a prevalence data. Okay. And regarding the screening, like sir was mentioning, one of the things is you're using a non-Medriatic fundus photos, right? So you are likely to miss many of the patients. You can only, this is only called as a screening. For screening, this is acceptable, but not for, identifying these patients on a prevalence. Like if you're doing a door-to-door, this has to be a more detailed, dilated fundus examination should have been done. So that's how you call it as a prevalence data. But all the same, this is a very interesting study that you have done, because it is also important to show the lacunae among the patients who are seeking care versus those who are not even aware of diabetes or diabetic retinopathy. It brings in the importance of reaching out to these patients. Is the need of the hour is that you have to reach out to these patients who are not seeking care. Anyway, that's a good study that you have done.
So, thank you, sir. If I could just reply to your comments, sir. Where you mentioned the epidemiological study, when it is a population-based study, definitely that is the most accurate thing which can be done. So when I reviewed the literature of whatever has already been done, there are some very good population-based studies, and there are some eye clinic-based data which is available, like the most recent available data of the SPEED study, which has been published in 2020 only. So what we thought was, when we are taking only an eye clinic-based data, we are already reaching these patients a little too late. So what can be done at a little earlier level? That is by reaching the diabetologists. So that is what the entire idea was.
No, true, very true. But what I'm saying is it's not the prevalence of the diabetic retinopathy among the population. It is the prevalence of diabetic retinopathy among the patients who are seeking care for diabetes.
Yes.
Definitely a good opportunistic screening that we need to do, and we have to continue to do. That definitely is very, very important, and you have brought out that factor very clearly. But I just wanted to stress on the point that when you call it as a prevalence data is all that I'm just pointing out.
Can I make a small comment here or a question actually? I'd like to know, like, how would you suggest addressing the missing link? The missing link has been identified. How are you addressing it? Do you have suggestions?
Yes, ma'am. So what I feel is that, again, as we mentioned, the awareness has to be in the young diabetic age group, that is whose diabetes mellitus age is less than 5 years. And again, we ophthalmologists are not reaching these patients because they are not seeking our care as yet. but they are regularly visiting a diabetologist at least 3 to 4 times in a year and are getting their blood tested. So at this point, if the diabetologist informs them, what has been seen that the pamphlets which have been given to them, their education material, sometimes the part of blindness that can be caused or the importance of eye screening is completely missing from that. And that was also shown by the diabetic retinopathy barometer study that more than 1/3 of the physicians do not discuss eye screening with their patients. So this be created a communication system which needs to be established so that they refer these patients regularly. And we will also have to give the same feedback to these diabetologists so that they feel encouraged to send their patients, and hence we can get treat these patients by primary prevention and not after an eye disease has already been developing.
Yeah. Yeah, just my point was to have some concrete idea on how you will address this and then proceed with that. Whether you want to distribute pamphlets or you want to have television talks on this repeatedly, national television. So how do you address the link finally? That's one thing you have to work.
So
yeah, can we, due to the paucity of time,
can be done is that, yes.
Can we shift?
Should I answer that?
Next.
No, that's okay. That was not a question. That's just.
I think.
Okay, that's fine.
Dr. Shamrup, is your presentation ready now? Dr. Shamrup, are you there?
Shamrup, mute yourself.
Yeah, you can now share screen. I'll once again invite Dr. Parikshit Gogate, a scientific committee member, to please invite Dr. Shamrup to deliver his talk. Dr. Parikshit?
I think Parikshit has already introduced Shamrup, so Shamrup can go.
Okay. Yeah. Shamrup, please go ahead.
Okay, sir.
Sunil, please note the timing. Share screen, Shamrup. Yeah.
Sir, please put it in PowerPoint show. Function F5.
Shamrup, PowerPoint mode, please.
Function F5.
Onto the F5, you can press F5, Shamrup.
Or you can, if you're starting the timer.
So the icon on the bottom next to 47%, you can click that. At the bottom of the PPT next to 47%, there is an icon.
Right corner.
Yeah, just the presentation mode, Shamrup. Down below.
Yes.
Is it okay?
Yes, next to 47%, there is a left to 47%.
Yeah.
Yes.
Absolutely.
All good, sir.
Yeah.
Thank you once again, all the judges, for giving me a second chance. And I'm really sorry about the technical glitches. Coming to my topic, I'm going to share retinal changes in hypertensive disorders of pregnancy. The scenario in Tripura. The incidence of preeclampsia in Tripura is much higher, that is 87.5% compared to national standards, which is 8 to 10%. Yet, from the ophthalmological viewpoint, no study was undertaken. Therefore, I understood this study to observe the retinal changes, changes in pregnant women, and to correlate some of the neonatal parameters. The aim of the study was to document the retinal changes in different classes of hypertensive disorders of pregnancy. The objective was to find out the relation between retinal change and different classes of hypertension disorders of pregnancy. And secondary objective was to relate these fundal findings with neonatal parameters, neonatal outcomes. Dilated fundoscopy was done, and biochemical and neonatal parameters were noted. The statistical analysis was done. The total number of 150 patients were examined, and they were grouped as those having retinopathy and those not having retinopathy. And after the calculations, various statistical methods were applied. Coming to results, around half of the patients had normal fundus and the other half had retinopathy. The retinopathy group mostly consisted of severe and moderate systolic blood pressures. And Grade 1 retinopathy was commonest, 27.33%, and grade 4 retinopathy was least common. Coming to arteriolar constrictions, focal constriction was the commonest finding, that is 40.66%, and generalized constriction was considerably less, only 30%. Arteriovenous ratio of 2:3 was preserved in 48% of the cases, and some cases showed, around 12% showed an AB ratio of 3:5. Coming to arteriovenous, one of the most remarkable findings in hypertensive retinopathy. Arteriovenous knitting was found in 15 patients, that is 10% of the patients, and other had normal arteriovenous crossings. In the retinal background, most of the patients were normal, 88%. Hemorrhage was found in 17 patients, that is 11.33% patients. Retinal edema in 8%, hard exudates 2.66%, and remarkably, cotton spots were not found. Macular edema found in 2% patients. And the most interesting observations came in neonatal parameters. And those having retinopathy were found to have significantly higher requirement of cesarean delivery, that is around 89%. Unfortunately, there were 3 stillborn babies, and they belonged to the retinopathy group. Quite interestingly, most of the severe retinopathy cases were actually harboring a male baby. There was significantly higher incidence of low birth weight. There was significantly higher incidence of low birth weight in the retinopathy group, and Apgar score was little depressed in the Apgar score at birth was little depressed in the retinopathy group. However, it was not that much statistically significant. We also tried to look for retinopathy of prematurity and or congenital anomalies, but we didn't find. Among the biochemical values of the mother, the mean value of serum bilirubin was high. In conclusion, it can be said that retinopathy was found to be associated with more adverse maternal and neonatal outcomes. And finally, a recommendation may be made to the government for including ophthalmological examination in the antenatal checkup of hypertensive mothers. With that, I would like to conclude my topic. Thank you all.
That was a nice presentation. I would invite the lead judges for the presentation of Dr. Shamru, Dr. Kim Ramaswamy, and Dr. Malika Goel. Dr. Kim Ramaswamy, please, sir, for your comments.
Thank you, Dr. Shah. That's a very, very interesting study. And you brought out the saying that most of the cases, almost 80% have preeclampsia in that state. Is that something? Is there a reason for that?
Sir, exact reasons are not clear, but observations were like this.
That's interesting. And I just wanted to point out, you had mentioned like 41% had, you said, have focal constriction. Focal constriction happens as grade 2 of hypertensive retinopathy, not grade 1 of hypertension.
It should have been in, yes sir, it should have been observed in,
yeah.
It should have been observed in mild retinopathy cases.
Correct.
But somehow in this case.
Okay. Okay. And the prenatal features, like you have correlated a lot of those with retinopathy. Do you think that is a causative factor and, for these neonatal parameters? You know, a lot of those parameters that you mentioned associating with retinopathy. Do you think there is a cause and effect in that? Or is it just a coincidental finding?
The fatal outcomes here are contributed by multiple factors, and retinopathy may be one of them. However, at present, it seems to be a cause and effect seems to be an incidental finding.
It's an incidental finding.
However, I think some more study may be done on that to confirm whether it's just an incidental finding or whether there is any cause and effect relationship.
Okay. The other thing is, how many of these patients, did they have any pre-existing hypertension, or is it all related to pregnancy?
Actually, sir, the data is based on antenatal checkup in the hospital. So, which of the patients were having pre-gestational hypertension, that is not clear. But the study included those who had been diagnosed as having hypertension due to any etiology during their antenatal visits.
Okay, it's really an interesting study, but we need to know the causative reason for why so much of association is happening. Dr. Mallika?
Yeah, thank you, Dr. Kim. Yeah, I think the topic itself is extremely good, doctor, and because, as eye doctors, we really don't understand the significance of these changes, and it's actually a very important prognostic marker for the maternal morbidity, mortality, as well as neonatal mortality. So this is something which most of, sorry. So this is something which most of us do not know, actually, that our findings can actually direct the obstetrician into a particular direction of treatment. So if it is a stage 3 or stage 4, particularly stage 4 retinopathy, they are supposed to terminate the pregnancy immediately, because the fetal mortality is extremely high, almost 100% if it is stage 4. So I would like to know from you, what is the reason that hypertensive retinopathy can guide the obstetrician into treatment, or why does it prognosticate fetal mortality? Can you tell us that? What is the correlation?
As far as fetal mortality is concerned, hypertensive findings in the mother don't appear to have any direct correlation. But if the mother has stage 3 or 4 retinopathy, she might be landing into an eclampsia, and normal delivery might be difficult, and also it may lead to maternal death and all. Therefore, it seems prudent to terminate when there is indications of when there are definite proofs of having increased intracranial pressure, mainly in the form of papillomas or grade 4 retinopathy.
No, I don't think so. The fundus changes, retinal vascular changes, reflect the changes in the placenta. And so the ischemia to the baby is the reason for fetal mortality. And that is why when you see more and more severe retinal changes, it is the child which is going to die from ischemia. That is the main reason for urgency. So this is a very good topic that you have chosen. The only thing you needed to probably highlight the correlation with prognosis a little better, because that is the whole basis for doing all these tests. And yeah, definitely obstetricians have to involve the ophthalmologist in the care of hypertensive patients. It's very important. It's very important. I think that's all. Even exudative retinal detachment is a sign of choroidal ischemia, and hence a sign of fetal.
We looked for that, ma'am, but I didn't find. I looked for that.
Yeah. Okay. Right.
Great presentation, Shamrup, and excellent points. I think even I'm finally learning something about it. Unfortunately, we're slightly behind time, so my apologies, but we'll move on to the penultimate presentation, which will be by Dr. Soham Basak. And to introduce Dr. Basak will be my friend and mate on the scientific committee, Dr. Feroz.
Thank you, Dr. Sunshila. So we have the slide on.
That's my cue.
Okay. Yeah. So hi to everyone once again, and I'm extremely happy to introduce Dr. Soham Basak, who is a very vibrant and young cornea and anterior segment surgeon at Disha Eye Hospital. And he's an alumni of Arvind Eye Hospitals and Massachusetts Eye Urine Infirmary. So basically, he has represented India and won various awards internationally. And one of them is the Achievement Award of American Academy of Ophthalmology recently in 2019, and various national awards as well. And I'm sure he has something really interesting to present today. Welcome, Dr. Basak, and over to you. All the very best.
Thank you so much, Fairuz Madam. Good evening, everyone. My talk will be on air-assisted donor lenticle insertion in DSEC in aphakia. I have no financial interest in this talk. So we know that DSEC in aphakia, especially with large iris defect, is quite challenging. Achieving a good air tamponade and lenticle adhesion is difficult. And there is the risk of the donor lenticle dislocating posterior. So surgeons have come up with various modifications, like putting an IOL in first, having various suture fixations and suture supports. Some use various scaffolding techniques. So here is my novel modification for this sort of situation, where I use an air-assisted technique to maintain the AC during all the steps. There is no use of sodium hyaluronate intracamerally. The donor insertion takes place with a pre-existing air bubble in AC. There is minimal donor manipulation and no to minimal fluid air management. So a short video. So we have a young man, one-eyed, with chorioretinal and iris coloboma, underwent VR surgery and then developed a corneal decompensation. So after peeling off, we notice some emulsified silicone oil. I take care of the BSK with quick EDTA chelation, and then move on to the DSEC main surgery. So prior to doing anything, the incision needs to be quite large in this case, so it's a 5.5. The emulsified oil is removed with the bimanual eye, and now we put in an air bubble in, and this air bubble stays. So DM scoring takes place under the air bubble. And notice that I have not made the main incision here yet, so that the AC stability is better. So once the DM endothelium complex is completely stripped, then the main incision is made. So there was a little moment of tension because the stripped endothelium got dragged, but fortunately did not drop behind. Here I retrieved it out with the forceps. So then the prepared DSEC graft. So I use a needle insertion technique after coating the incision area with Helon. So this is where the technique takes place. The lenticle is guided carefully over the air bubble and under the host stroma, so that the air stays underneath, supporting it so that it does not drop behind posteriorly. And as you notice, with a large incision, there is no need for any folding techniques. And the incisions are secure. And then finally, we do complete airfill. So this is the post-op of the same patient at 1 day and 6 months, and the sequential anterior segment OCT images. So over the last 10 months, I have done 7 eyes of 7 patients with satisfactory visual outcome after refraction. There has been no incidence of dislocation or rebubbling required. Specular, unfortunately, the follow-up is little irregular. So we have 2 follow-ups, one at 30 and one at 25% cell loss at 6 months. So for DSEC in aphakia with large iris defects, this technique of doing an air-assisted donor insertion is a safe and repeatable technique. However, longer follow-up is needed to assess the long-term graft survival status. Thank you, sir.
Yeah, Dr. Somshila, I think you are muted. You can, the lead speakers for the talk by Dr. Soham Basaka, Dr. Vanati, and Dr. Rajesh Fogla. Dr. Vanati, please, for your comments. You're muted, Dr. Vanati.
Yeah. Thank you, Dr. Balla. That was a very fantastic video demonstration, Soham, of air-assisted technique of aphakic, DSEC in aphakia. We agree it's usually a more challenging scenario when you have to put in the donor lenticule where you're in a scenario when the eye which is aphakic and the lenticule can drop behind. But I think you had excellent control with an air-filled chamber and were able to introduce your button in well and hold it in place. I think what I would like you to highlight is, as you said, there are only 4 cases and you still need a longer follow-up in order to look at the endothelial cell viability and the loss in these, the attrition, endothelial attrition in these cases when you're using air as the medium to hold your button in position right throughout the entire procedure, and how it would probably compare vis-a-vis the other routine standard techniques which are used for DSEC lenticular insertions here, compared to your newer air-assisted techniques. So those would perhaps add on more substance or enhance the results of your study, and will also help you to scientifically document it as a non-inferior or an equivalent technique to the other described ones here. I think well done, and it was a fantastically demonstrated video. Dr. Fogla?
Yeah, I agree with your point, Dr. Vanati. Congratulations to Shoham for demonstrating the surgery so elegantly in a very controlled manner in a aphakic eye with a very large iris defect. Yes, the main problem that I foresee in such cases is the ability to retain the air bubble in the anterior chamber, both intraoperatively and in the postoperative period. Here, because your iris defect was inferior, that's why maybe you were able to retain the air in the anterior chamber. But if you would have had a superior iris defect, the problem would have been compounded by the fact that the moment the patient sits up, the air bubble would have gone into the posterior chamber. Intraoperatively, there is a tendency, once we put in the graft into the eye, we try to pressurize the anterior chamber momentarily, at least for the first 7 to 8 minutes, to try and remove the fluid from the interface with that tight airfill. In this scenario, were you able to achieve a tight airfill? Because even in the video at the end of surgery, your eye pressure did not seem like very firm. You were able to depress the eye and the pressure looked like somewhere within the normal range. Any comments you would like to make, Soham?
Yes, sir. So points definitely taken. So 2 modifications I make is, one, I make the patient lie down on the OT table for 1 hour before moving them elsewhere. 2, I'm not doing a fluid air exchange at all at the end of the surgery, because I expect the air to escape out. And most of them, when I see them at maybe 2 to 3 hours after the surgery, most of the times the air has definitely migrated posteriorly. So in this case, initially I was not able to achieve a good airfill. It was somewhere in the high 20s, but finally just before where the video cuts out, I was probably able to reach somewhere around 40. But I compensate by ensuring that the patient stays still in the OR before I move them and shift out to the recovery room.
So that's the difference that we have seen between DSEC and DMEC is, unlike DMEC, where you need a continued presence of air to tamponade the donor lenticule, in DSEC, sometimes intraoperatively also, if you can achieve a good pressure in the eye for 8 to 10 minutes, and even if you can keep the patient supine for the at least first hour, after that, even if the air disappears posteriorly, the donor disc tends to remain in place. Would you like to make your donor disc thinner in these kind of cases to achieve better adaptation?
So So I have other videos, but the problem is when it's a very thin graft, when you're doing that insertion, it tends to fold on itself. And then unfolding under air becomes very difficult. So I would like to have at least maybe, it's an eye estimate, but maybe around 120-ish micron thickness. So that in this case, it did not fold at all. So I was quite lucky with it. Most of the times it requires a little nudging for it to unfold, but very thin grafts, it folds and that becomes
right, are not a very large level. Otherwise, when you try to push your disc in, you have kind of leaking out, which can
yes, sir. So the wound baking is very important. I think that is probably the key step for achieving this technique.
Dr. Palla, can I make one small point?
Yeah, sir. Please go ahead.
I am a foreign body to cornea, but Rajesh, you see, because for air to continuously support the lenticule, what Soham very nicely said, can you take a small 30 gauge needle connected to air pump like we do in VR surgery, so that air does not, there is a continuous air supply inside, instead of putting once and then depend on that bubble. You see, what sometimes I do is that 30 gauge needle, which is connected to a air pump of the vitreous machine, so that air pump continues the support.
Can be done. The only problem is here, if the iris is rigid, it doesn't come up. But in certain other scenarios, if you have a significant amount of air going behind the iris, it will push up the entire iris forward, and sometimes it comes very close to the graft, and then you have to go back behind the iris and remove air and then try to reform the anterior chamber. But it's important not to have hypotony. If you have hypotony, then the tendency for the air to go behind will be much more. So before you put in an air bubble in the anterior chamber, you should normalize the eye pressure by injecting fluid, and then put an air bubble in the anterior chamber. Because then the eye pressure is normal, the air will not tend to go posteriorly. But if the eye is hypotonous, you will overfill and the air will definitely escape to the posterior chamber.
I think you try this, because continuous insufflation can be done with this.
In the earlier days, interestingly, it was done actually, continuous insufflation, and with the 30 gauge needle.
Yeah.
So again, Dr. Balla, can we move to the last?
I think now it's my pleasant duty to invite the last batsman of the today's East Zone Talent Search, and it's none other than Dr. Vedang Shah. Dr. Vedang Shah is completed his MS Ophthalmology and with VR fellowship from the esteemed Arvind Eye Hospitals, Madurai, and he continued working as a consultant there before returning back to Kolkata. He's currently working as a consultant at Sri Netra Eye Foundation, Kolkata, and his special interests include OCT angiography and retinopathy of prematurity. Over to you, Dr. Vedang, and all the very best.
Thank you, sir, for the introduction, and thank you, AIOS, for giving me the opportunity. Is my slide visible?
Yes, it is.
Yes, Vedang.
Open angle glaucoma is one of the major causes of blindness in the world, and there are numerous pathogenic mechanisms. Though one of the major risk factors, newer studies have shown that reduction in ocular blood flow may play a greater role in the development of glaucoma. Previously, Doppler OCT and laser speckle flow metrography have been used to record the ocular blood flow in the eyes, but these are not repeatable. Hence, OCT angiography is a mechanism which is non-invasive, repeatable, and helps us to monitor the disease progression. So the purpose of my study was to examine the density of active flow vasculature in the macular area of glaucoma patients compared to healthy patients using the OCT angiography. The patients who were included, the normal and the control, matched the inclusion and the exclusion criteria, which included the diabetic and the hypertensive retinopathy, unreliable visual fields, and poor quality of OCTA. Healthy eyes were defined as eyes with pressure less than 21, normal appearing in optic disc, and 2 reliable normal visual field patterns. Glaucomatous eyes were defined as eyes having optic disc appearance of glaucoma with evidence of repeatable glaucomatous visual field damage. And it was observed also in the stereo photographs. Similar was noted in the perimetry, and the GHT and the pattern standard deviations were seen to be outside the normal limits. So this was a prospective cross-sectional observational study and the patients underwent the tests like BCVA slit lamp, fundus dilate examination, visual field testing by automated perimetry, OCT-RNFL, and OCTA imaging. The OCTA imaging included 6x6 mm macular angiographic scans and the ONH angiographic scans. The foveal density, perifoveal vascular density was noted in an annular centered on the fovea with an inner diameter of 1 mm and an outer diameter of 3 mm. So this is to give an idea as to how the OCT angiography slabs appear. And in glaucoma, to look for the glaucoma in these eyes at the peripapillary junction and also at the macula. Why macula? Because 30% of the ganglion cells are at the macula. These are a few images from the normal and normal patients and from the glaucomatous eyes. The OCT RNFL, the OCT angiography depicting the annular ring over the macula in a normal subject showing the vascular perfusion density. This is from a glaucomatous eye depicting the vascular density at the center and also in all the superior, inferior, nasal and temporal quadrant. Another one from the glaucoma eye. ONH angiography was also done. So this is one from the normal eye and ONH angiography seen from a glaucomatous eye. So the age-matched patients who were taken in both in glaucoma and control groups, and standard automated perimetry was performed before doing OCT angiography in these patients. And it was noted that it was statistically significant in all the quadrants except for the nasal quadrant. And the p-value was noted to be less than 0.001. I think the nasal quadrant was not statistically significant, and it could be because of the papulomacular bundle. So vascular flow density was found to be significant in the glaucomatous patients. Superior and inferior perifoveal areas were found to have maximum reduction in the flow density, and the flow density in the nasal perifoveal quadrant was not noted to be significant. Comparative studies have been done, but they have been done on the peripapillary plexus and not on the macula. So the significance of my study is, according to the vascular theory, the optic nerve damage is a consequence of reduced ocular blood flow, which can lead to axonal damage. There is a theory that states that the destruction of neural tissue happens, resulting in secondary microvascular changes. But in my current study, I have noted that the macular flow vessel density was significantly less in glaucomatous eye as compared to healthy eyes. Therefore, this microvascular mismatch indicates that vascular damage may be faster than the neuronal damage in early glaucoma. Few limitations because of age and because of systemic medications or because of the ocular hypotensive medications that the subjects may be using. There are still some unanswered questions whether this circulation loss occurs gradually or is it episodic, whether there are ocular systemic physiological factors that could affect microvascular perfusion, or is there the capillary density loss first followed by nerve fiber layer atrophy. This remains to be answered. These are my references. Thank you so much.
Thank you, Vedant. Can we have the judges, please?
I think that was a very good study, Dr. Shah. There's been a lot of interest recently in OCT angiography, especially in relation to glaucoma, and you will find a lot of literature. I think is quoted also on the optic nerve head, the peripapillary retina, and also the optic or the macro area. In your study, was it mostly qualitative data like analysis, or did you calculate any indices, which are many studies actually they do nowadays?
Yes, sir. Can you repeat the question? I was not able to hear it.
Did you have was it a mostly qualitative analysis of the images, or?
It was more of a quantitative analysis to look for the vascular density. So
okay,
the vascular density was noted in all the quadrants, and depending on the vascular density, the further analysis were made between the normal patients and the healthy patient and the glaucomatous patients.
What algorithm? How did you get the index? Which software did you use for that?
So this is a software which is inbuilt in the OCT machine that I am using, and the annular depiction over the macula is seen in the superficial vascular plexus when we want to look at the imaging perfusion. So this is there inbuilt in the machine.
This is also dependent on somewhat on the kind of algorithm that you use, but that's okay. I think the important thing here is that to control for any confounders. So do you think there are any confounders in your study?
So the confounders could be age-related depreciation in the vascular density. So that is one of the major reasons. The other reason is it has been shown using OCT angiography that after the use of beta blockers in patients with ocular hypertension, there has been an increase in the vascular density. So these hypotensive medications that we were using in some of the patients.
You had control for vascular hypertension and diabetes.
So these patients were not included in this.
Yes, and they're also age matched. But
yes, yes.
What about the IOP? Like one was the normal and other was glaucoma patient. So what was their baseline IOP? Could IOP influence the angiographic findings? Because if one group had higher IOP,
yes,
you could expect some changes because the raised IOP in that group. So did you account for that in this study?
So sir, that was one of the questions that I had placed at the end, the unanswered question, whether the circulation loss, is it constant or is it episodic? Just like how the IOP varies with the diurnal variation is there. Similarly, the variation in the angiographic or the vascular perfusion could be affected at that spontaneous moment, but the density would not be. Sorry.
You're talking about the diurnal variation in angiography.
Yeah, no, I'm not talking about the diurnal variation, sir. I'm talking about the diurnal variation of the IOP may happen, but the variation could be because of the vascular flow, but not because in the vascular density. So basically, we are concentrating on the vascular density of the thing around the macula.
My question was actually, can IOP,
yes,
not related to diurnal variation, high IOP in group could change the vascular density. So that means the IOP at the time of OCT acquisition would be important.
Yes, sir. Yes, sir. Agree.
So we need to know at least the mean IOP in the two groups. At least we need to know that much, right?
Okay, sir.
And the other confounder here would be the therapy. So the treatment that you give for glaucoma, you did mention about the systemic timolol, like you give for hypertension or other reasons.
Yes,
but what about the topical timolol eye drops? So I think you need to control for that also somewhere, to make these two groups comparable.
Yes, sir. The systemic ocular timolol has been shown to increase the vascular density. It has been shown in studies done by OCT angiography.
So I think you need to include that in your analysis as well. Did you make any other comparisons like the density versus other structural changes like retinal fibrillary thickness or the RGC complex in these patients?
So I have noted all these findings. The previous studies have already shown the change in the RNFL thickness and also change in the peripapillary vascular density. The point here was in the previous studies, the macula scans have been also analyzed, but the scans have been analyzed in 3 into 3 mm scans. The slabs have been smaller, and these slabs are not attainable, can be increased to 6 into 6 mm in the recent angiographic machines. These 6 into 6 mm scans will acquire the arcade to arcade architecture and thereby increase. So the previous studies have shown that only superior and inferior part of the arcade is affected in the vascular density. But in my study, I have shown that all the arcade, all the superior, inferior, and temporal arcades are affected, except for the nasal cord.
Thank you. Got your point. I think maybe I'll pass it on to Dr. Shea.
Yeah, it was very nice presentation and nice study. I just wanted to know whether you have included patient in inclusion criteria, whether you have kept the IOP as a one of the criteria, means all the control IOP patients you have examined, or there are variations. So if variations are there, as Dr. Pando was asking, is there any correlation between these variable IOPs to the angiography, OCT angiography? And second thing I wanted to know about the CD ratio. Was there any relation between the CD ratio and OCT angiography in these cases?
Ma'am, regarding the IOP, as I mentioned before, I divided them into healthy eyes and glaucomatous eye based on my criteria. where the IOP was less than 21 and greater than 21, and depending on the glaucomatous visual fields, which were repeated on 2 occasions. Apart from that, the IOP measurement on the day of examination was done, but not just before the OCT angiography. And the second point that you made regarding the cup disc ratio, I have not done any correlation on that, but I would expect that the correlation will be there, considering I think a better analysis of the cup disc ratio with the peripapillary vascular perfusion would be a better study to analyze that.
Thank you.
Thank you, ma'am.
I think those were wonderful comments from the esteemed judges. Dr. Vedang, if I may ask you, could you?
Yes, sir, please.
Yeah. Any change do you expect between the functional changes like color Doppler imaging and the OCT angiography of peripapillary and the macula?
So the difference would be definitely in terms of repeatability and in terms of assessing the monitor progression. Because using the OCT angiography, the same scan and the same area can be highlighted and seen, which probably may not be achievable by ocular Doppler flow or by the speckle flowmetry, and that is why these tests are no longer in use. So that would be one of the major reasons why OCT angiography is repeatable, plus it's non-invasive.
Right. I think.
All right, we hand over to Dr. Biswas now.
Unmute.
Thanks a lot. And I think we have seen a fantastic set of presentation. A small reminder to our judges who have not yet submitted the mark sheet, if you could kindly do them. And in 10 minutes, the results would be ready. So have all our honored judges submitted the mark sheets. And we have the pleasure of having our president AIOS with us. Sir could not join because of certain commitments, but he's here with us. Maipal sir, a few words from you, sir.
Yeah, thank you very much, Partha. I think as this is the next episode, which is the East Zone, it has been a pleasure all through to get this new talent and the exciting discussions that happen. And as was pointed out earlier by all of us, I think we need to encourage the youngsters because they're doing great work, and I'm sure that they will take Indian ophthalmology to greater heights. Ideas need to be put into practice, and they need to be that is the intellectual property right of the individual. And I think, as was said earlier, AIOS in its part should try and have courses. Maybe Partha, you can arrange, or AIOS, we can look at it for the intellectual property right to get the patents and things like done for all the people who are participating in it, because this is actually, it's the intellectual property right which takes an individual to a different level altogether. So the encouragement needs to be given to all the youngsters who are participating with their great ideas. And I think it's the, जैसे वो कहते हैं अपना टाइम आएगा, I think India's time in ophthalmology has come, and we have the skill set, we have large number of patients, we have technology, and I would say that ophthalmology is no longer a poor man's practice, because things have evolved significantly, and I think it is going to be, and it is becoming a preferred choice for a lot of the toppers and the brilliant people in the medical fraternity. So all that I will wish to say is that keep up the good work to the youngsters, and we are right there to try and help you to the best of our ability. But it's your hard work, your perseverance, and your thought process. I would say that you need to have a clear thought to achieve something that is going to take you to places. So best of luck, and I would say that everyone who participated is a winner in himself. Obviously, there'll be only 3 or 4 people who will move on to the final, but I think the mere fact that you people had come out with brilliant ideas and have participated in itself something great, and for everyone, a really great job done, and look forward to the results being announced soon. Thank you.
The results are just coming in, sir, and we have all our honored judges. Quick comment from all of you on the youngsters whom you have heard today, and what do you think of them, sir? Mangat, sir, Dr. Mangat Dogra, sir.
Thank you, Dr. Partha, Dr. Mahipal, for this opportunity for me to be here and part of this elite group of judges, and especially the way Dr. Mahipal said, the ophthalmology where it is going, and the standard of presentation and the innovations and the ideas which has come up today. At least I'm really impressed. And what Mahipal said, that we need to definitely have more, some channel, even from AIOS, to have them patented some of these, because that is where we lacked in past. And most of the presentations, we have seen new ideas coming in, and that is what is the need of the hour for Indian ophthalmology. And that's what is going to take us further as far as our image in the international ophthalmology is concerned, and also more publication of high standard coming out of it. And that is possible with these kind of varied presentation with new ideas and innovations. So thank you for inviting me to be part of this team.
Thank you very much, sir. Dr. Pandav, sir.
Thank you, thank you, Dr. Partha, for giving me this opportunity to listen to so many young, bright people, and thank you AIOS for this platform. I think some of the presentations was really good, and most of the time we are restricted to our own specialty. And this was a very good opportunity for me actually to learn from other people in the cornea, retina, and what they are what's happening there, and some of the very bright ideas, because this cross fertilization of ideas is also very important, especially when in this area when you are sticking to one super specialty. So I think that's a very good platform. And as already been said, some of the presentations were really very good, excellent presentations, and had very new ideas. And certainly we need to nurture this culture. I think it's a very good platform by the AIOS, but we need to promote it further. And also we need to develop that that culture of having our intellectual property, attach more value to it, attach more prestige to it. And I think that is sort of starting to happen. And I think I must congratulate you for taking the initiative and lead the AIOS for providing this platform. So I'm very glad that I'm here today, and thank you very much for this opportunity. Thanks.
Thank you very much, sir. Our other judges, Dr. Vanati, Dr. Malika, Dr. Kim, Rajesh, please, your comments.
I think we have to congratulate Dr. Partha first for bringing out this, because but for this forum, this opportunity for all the youngsters to showcase their talent is not going to be there. And then today that opportunity is widely available, and that's what I think also pushes a lot of these people to come out with a lot of ideas, because there are opportunities to do, and these kind of forums actually help, as Surinder said, cross ideas and stuff. It really brings out. So I really congratulate, and I'm sure Dr. Partha would have more such ideas to bring the talent out. Thank you, Dr. Partha, for doing this, and the AIOS team.
It's been a collective work of the whole scientific committee team, sir. Thank you so much.
Yeah,
Yes.
Dr. Biswas, I would like to say that, I would like to commend you for this novel concept of repeatedly getting the youngsters forward. And so congratulations on that. Also, it takes a lot of courage on the part of these presenters to, come and show their material and then be open to criticism. So I would like to tell them that even those who could not get the, this position first, second, or third, they should not feel discouraged. They should have some learning points from what they missed out, how they can further improve their studies. because each one of them has done a very good job. So
Thank you.
congrats.
Rajesh, then Chaitra.
I agree with all the points enumerated by all the other judges. And the other important point is that there is a lot of hesitation among members to come forward and participate in such activities. So what this exercise that you have conducted, hopefully it will inspire more people to participate in future programs. I'm sure a lot of people have ideas, but they are just, shy or hesitant to come forward and showcase them. And these kind of programs definitely will help bring out all the talent that we have among all the youngsters.
I think it's been an amazing, 2 hours because we got to see a whole lot of ideas. And I think what was also important is the regional, importance that was given, because I think some conditions are very niche to that particular area, and that's been picked up and studied. And second thing is, I must appreciate the confidence with which they all presented. It's not easy, even though it is an online platform. The butterflies in the stomach do not go away. So I think you guys rocked it. You all did an amazing job. And it just shows that these can be very small but important stepping stones for bigger platforms. It could be at the national or at the international level. I think you all did wonderfully. And each one of you all is a winner just for the fact that you all participated. I think that's extremely important. So congratulations to all of you.
Thank you, Chaitra. And it was, we have
we hear from Vanti also. We hear from Vanti, yeah. You have to unmute Vanti.
They're all sort of standing between the results. The contestants are equally.
You are the last one to pass the comment.
Once it has been a fantastic, I think, modem of bringing in young talent and showing it out. And this is going to encourage more of the youngsters to boldly come forward and shed their fears and inhibitions and share their ideas in front of a panel. And this potpourri is really a wonderful way in which we are all sort of cocooned into our own specialities. We do get into, peep into all the other things as well. It has been a fantastic forum. Congratulations, Dr. Partha and your entire scientific committee team. We'll look forward to much more on similar innovative ideas in the coming near future.
Thank you. Thank you very much. And that's a huge amount of thanks to the judges who have stayed up so late and taken time off from their busy schedules. Thank you very much, all of you. And of course, thank you to all the participants. And the marks, they are nearly neck over neck on each other. So
I hope there is no tie this time.
Yeah.
So no super over.
So thanks to the participants and thanks to our sponsors, Intas. And Intas has done a great job. They are sponsoring all the talent search programs of AIOC Scientific Committee. And we are really grateful to them. So now we come to the marks and the results. So the 3 who will be going on to the semi-finals and finally to the finals are 3 from the East Zone, 3 from the West Zone. 4 have already, because of a tie, have already gone in to the semi-finals from the South Zone. So we have to announce today, right now, 3 from the East Zone. And who are them? So we will not disclose who has come first or second or third, because that would be a bias when they come to the semi-finals and finals. So we'll have Dr. Mahipal sir give out the name of the first of the 3 winners. They could have been in position 1 or 2 or 3, but they are the 3 top from the East Zone. So Mahipal sir.
Thank you very much, Partha. Indeed, my pleasure to announce one of the winners, and that is Amrita Mohanty from Odisha. Congratulations, Amrita.
Congratulations, Amrita.
She doesn't even have a smile on her face.
Thank you, sir.
Fantastic, fantastic. So Amrita, you're there in the semi-finals, and hopefully we'll see you in the finals as well.
Definitely.
Same as HRM material.
So Lalit sir is going to announce the name of the other one.
So, in fact, I learned a lot in this entire 2-hour session, more than 2-hour session, and congratulate the entire scientific committee team because it motivates everybody. And it's my proud privilege to announce one of the three. Like Partho said, it may not be in sequence, and it's the air-assisted donor lenticule by Soham.
Congratulations, Soham.
Thank you, sir. Thank you, sir.
Congratulations, Soham.
Thank you, sir.
Where are you? I can't see in the screen. Yeah. Okay, great.
So we finally have the third one who is again going into the semifinals. And this is Nilesh Kumar. So a big round of applause for Nilesh. Fantastic.
Thank you,
And again, we must tell you that we are not disclosing the marks, but the marks are absolutely neck to neck. So if you've been the top 3, the others, the rest of the 10 are nearly on you. So it's been a real wonderful gamut, and congratulations to all of you who have participated. Thanks a ton. So let's have these youngsters say a few words. Whoever. What did you think of?
Sir, thank you to AIOS for giving all of us this opportunity. It has been a pleasure coming in, preparing, and then speaking in front of the esteemed judges and the chairpersons. And definitely, as some of the judges said, these are small steps that we are taking in our initial practice, in the initial times. And with your support and with your mentorship, all of you definitely will look forward to exciting projects and even a bigger learning platform. Thank you so much, sir.
Thank you, Vedant. Thank you. So any of you, yes.
Yes, sir. I'll go, sir. Thank you for the opportunity, sir. I have been very lucky to be able to present in Think Under the Apple Tree last year. That was also your initiative. And now again, you have given another platform for us. So it's really great, sir, for AIOS to give new platforms to us youngsters. And I would like to thank AIOS Scientific Committee and the Governing Council both for constantly encouraging us. Thank you very much.
Many more programs, Nilesh, for the younger ducks.
Thank you.
More programs will come.
Thank you, sir. I would also like to thank my state society for providing me this opportunity, because that was their encouragement that made me come here.
Absolutely.
Thank you.
Yeah. Thank you, AIOS, for this opportunity. Like it has immensely boosted up, because being a beginner, we get really very scared when we present something very new. And thank you for this boost, and hopefully we'll keep it up. And thank you, Odisha Society, for providing me this opportunity to present my state. Looking forward for the next week. Thank you all.
So anybody else?
Yes, sir. I would like to say something. A great initiative by the AIOS Scientific Committee, and also thank you to the OSWB for giving me this opportunity to speak here. So definitely, youngsters, it's a great place for youngsters to showcase their innovations and work. And I think especially in this lockdown situation, having more platforms to share our ideas makes it all the more exciting.
Excellent. Very good. Very good. So anybody else, a word?
I would like to thank the AIOS committee for giving me the opportunity to present in such a huge platform in front of such eminent and experienced ophthalmologists. This is just a beginning for us. And I would also like to thank the Ophthalmic Society of Manipur for giving me the opportunity to present here.
Great. Wonderful. So
before we conclude, I would like to say, I was just sharing with Dr. Kim sir. I feel more proud. We are seeing so many Arvind alumni people participating in this. I feel really proud that we are doing great work. We are getting all the talents out. A lot of institutional people are coming out. LV Prasad, Shankar Mitralaya, Ames, Arvind. We're really proud of us. We feel as a scientific committee member, when our alumni people are there, we feel really proud. So thank you all my mentors and all the participants from various institutes to make this program a great hit.
Right. But we all saw that, each participant was so grounded and so realistic, and the innovation each one projected, the presentation, and just imagine years and years of hard work just in 4 minutes. And that itself is phenomenal. And the judges could take the best out of them, could provide that platform to, inspire them to tell what could not have been said in the 4 minutes. So thanks to all the judges for doing such a great job, and giving inspiration to all the youngsters, and making the best and making us so proud that you've been with us. So thank you very much, Lalit sir. Any last comments?
No, I am actually very happy that you have involved virtually all the 7 states of the East, and these 10 participants. I think they will remember for a long time that this opportunity was given, because the job of AIOS, especially the scientific committee, is to find out this talent. And I admire all of them, like you rightly said, to present the entire gist in 4 minutes at a competitive national level is not so straightforward. And hats off to these judges who were, who had a tough time. Like you said, all of them were neck to neck, and to point out that 3 people will go into the final stage. Congratulate everybody, and very proud of this scientific committee.
Thank you, sir. But before I hand over again to the moderators who have done the tough job of doing and rounding up everything. So thanks to the people who are the spine of scientific committee, that is Pallavi Datta. Let us give her a big hand. She works days and nights as well, listening to every request of ours, and she works very hard. Thanks to Sai from
Can we have all their photographs? Or at least video visible, Pallavi.
Hello, sir.
Pallavi.
Hi, sir.
Hi.
नहीं ऑडियो काफी है सर.
Sai Krishna.
Sai and Sunil and Kripal. These people work day and night for us, and to bring the show alive. This is the hard work that they do, and that is how we get this best of the best from this team of scientific committee. Thank you so much. And Lalit sir has always been an inspiration, and it's been a challenge to this scientific team to bring it at a level where he left it to us. So it is always.
You people are doing a great job.
Thank you, sir. Thank you. He is a guiding force. And thank you, everybody, and Dr. Kudlu.
Yeah, and Partha, Dr. Partha, don't forget Dr. Bala, and everybody, of course, Amit, Feroz.
No, entire scientific committee.
Despite being so busy.
Yeah.
Pallavi, I kind of missed you, and Amit accused me of blunders. So yeah, I'm missing you. That's why I made those blunders. Thank you.
Okay, thanks everybody. Bye-bye.
Bye. Good
Thanks.
night. Good night. Bye.
Yeah.
Bye.
Good night, everyone, sir.
Bye.
Thanks, Dr. Lalit, sir. Thanks,
Thank you.
everyone. Thanks, sir.
Bye.